and then pause whenever you take a breath, and unpause.
Keep going.
Yep.
Sure. Okay.
Yep. So we're gonna use my iPad to do the audio for those people that are watching at home. And I'll probably need to charge this bad boy sometime today. I charged it last night. So it'll get us through lunch, I'm sure. All right.
Yeah.
They're all yours. You want introductions?
Yeah, I'd like that. I'd like that.
You know this one, right?
Yeah.
Yeah.
All I need to know is who you are, why you're here. It kind of helps me with maybe changing things a little bit as we go. So if you're testing, just tell me that. And if you're
Randy
here for hours, etc.
Go ahead. You don't have to tell him the whole story. Just
I'm Randy.
Okay.
she's tested before and was not less than happy when she finished.
Okay.
Tammy from Brevard. Randy's from here.
Chad, just here for research hours. Good.
I'm Brittany. I'm here for research hours. And research hours.
Ted, I'm just here for research hours. Okay.
And Ted gets a distance award. He's from way the fuck down east.
I've seen Ted somewhere before. Where? And who's in the back corner there that's not in here now?
Oh, some of the basics.
Oh,
Randy's
okay.
teaching the basics.
Gotcha.
So if they're not in here now, other than being absent, and Maria's in the car still, or? Okay, yeah. Maria drove down here and now is in her car sick. Who is it?
Which Maria? Which Maria? Oh, okay. Sure. I'll take it very quick. All right, so a little story behind me is I was never a fan of National Registry at all. When I was in school, we tested it. I bombed it, and I said, "Well, I'm going to make it." So the one area that I lacked in was cardiology, and so I spent a couple of months just really knowing cardiology in and out. Took it again, scored worse on cardiology. And so I said, "I'm done. Thank you." It wasn't needed. Didn't have to do it. And so about 20 years later, I was at a community college over the training program, and I'd worked with Glenn a few other times. And he was like, "Well, I got time to do a prep in that area." And I was like, "Sure." And so it was always on weekends, so I was always off, and I always had to open the building and turn on the heat and all that kind of stuff. And so I sat down in the class, and he said, "Well, you're going to test, aren't you?" And I was like, "No." And he said, "Well, you've already, done everything. All you got to do now is your skills and everything." And I said, "I don't want to." And so he kind of conned me into doing it, and I did it. Everybody in the room hated me because when they're all freaking out looking at their skill sheets, getting ready to go into the various rooms or whatever, I was sitting there eating the donuts and making sandwiches and, just having fun. And there's a reason for that too. Number one, as an instructor over the years, if you stay teaching, whether you're good at it or poor at it, I'm not going to say which one I am. You'll figure that one out. Have your own opinion. But you learn things that are in a process, and that's all registry is. The written is a process. The skills are a process. There's a start point for your skills. There's an ending point for your skills. You can basically do anything in there you want correct in any order that you want to, as scatterbrained as you possibly can be, as long as you do it before you walk out the room and say you're done. And I'm not downplaying that at all, but it's true. And there's certain things that registry demands you do in just about every scenario. They've cut it down a lot. It's just becoming so popular. It's becoming it's really becoming a beast in the United States. It's becoming the standard. And so that's why a lot of you are here. And if you're thinking about, what are you going to do 10 years from now, I really encourage you to be National Registry and really be an advocate for it. So it really changed my mind about it, and I teach with it and alongside of it now. And we have lots of discussions, and everywhere I go. And one of the biggest ones is over something like cardiology. I'm gonna sit down some because I've worked all week. It's been a long week and I'm already starting the budget, so that's not fun. Every class that I do cardiology on for registry, there's always people in there saying, well, we don't do that where I work. And the response is what? What do you think the response is? Exactly. It's not about North Carolina. It's not about your local system. It's not about whatever state you're from and whatever you fall under. There's certain set guidelines for it. Like I said, everything has a method for National Registry. And if you sort of figure that one out and follow it, you'll do absolutely fine. So I'll give you some really good hints for those of you that are going to test it. When I say hints, these are things that, you know, there's no rhyme or reason to it other than you just have to trust me. So when you go take the computer adaptive testing, you go do your exam, about the first 5 questions or so, I'll need you to be the dumbest, slowest medical responder that there is in the United States. So there's about the first 5, 6, 7 questions. I expect you to be there about 10 minutes. Here's a good example. You have a patient with very mild respiratory distress. Their oxygen saturation is 93%. Their skin is warm and dry. What oxygen delivery device would you like to use? Non-rebreather, bank valve mask, nasal cannula, Venturi. What do you think? And everybody's going to go, for real? They're going to sit there and they're going to think, you know, the smart ones are going to reread the question and look at all the answers. And they're going to go back and look for something they missed, and they're going to look at all the answers again. They're going to click nasal cannula, and they're going to wait just a second. They're going to read it again, and they're going to move on. The ones that don't care are going to click nasal cannula and move on. So about, you know, let's just say that's question number 5. Question number 6, if you click that and you move on really quickly, question number 6 is going to be, after experiencing a STEMI and this medication is given, and this is the patient, what do we do next? And you're like, holy cow, where did this come from? So that first little bit, make sure you're really, really slow down. One of the things, if anybody tells you anything about computer adaptive testing, that you will not run out of time. And everybody says, well, I heard about this guy or this gal that they ran out of time. Yeah, they always pass though too, because they were being so anal retentive about it. So take a really lengthy amount of time on your written. Really, really long amount of time. So let's talk about test taking 101, just really, really quick. How do you do multiple choice questions? How do you analyze them? Because I mean, you can cite every study there is. There's people that are good at testing that have gone and taken the bar, and they've taken medical boards, and they're not doctors, they're not attorneys, and they've passed them. And I take a standardized test. That's all this is. It's just a computer adaptive standardized test. You have a question, read the question in its entirety. You look for pertinent negatives, like which of the following are true except, or which one would you not do in this particular situation. And you formulate the answer in your head, and then you go pick the best answer. And everybody in here says, well, there's more than one correct answer. That's not fair. Yeah. There's usually 2 very correct answers. One kind of correct, and one that's just not feasible at all. And for those of you that get lost and don't answer it, you can rule out and come down to 2. And always remember of the correct answers, which is the correct answer. You guys tell me. No, C is a good choice. B and C are quite often the ones that you pick, you just don't know. And this is not like a paper test. You can't find the answer in a question 20 questions later and go back. Once you click next, you're done. Well, yeah, and that's an important part of it is to not, when you're sitting there and you're getting ready to hit that and you know the answer, click it and move on. Go with your gut instinct. But the thing I'm looking for is one of the answers of the 2 correct answers is what you always do first, or it's the better appropriate choice for this particular patient. I created this question. This is the one I always use for every class that I do. So you guys think about this. Which of the following is not a sign of a heart attack? Not a sign of a heart attack. chest pain, pale skin, cold sweats, feeling of palpitations, or you detect an irregular heartbeat, which those is not a sign of heart attack, or it could be. And it's a very simple, basic EMT question.
What was the last one?
Irregular heart rate. So you detect your pulse is too fast, too slow, something.
Palpitation?
Yep.
Oh, I'll look at that.
Go back to the question. Think about the question. What did I ask you?
It's not a sign.
All those are symptoms except chest pain.
Oh,
I mean, all of those are signs except chest pain. Chest pain is a symptom. Sign is what you see. You can see and detect an irregular heart rate. You can see and detect cold sweats. You can see and detect pale skin. So everybody in here initially is saying, well, that's very tricky. No, it's not. It's National Registry because it's very straightforward. If you think about it, all their questions are quantifiable. In other words, over 100 people have looked at it and said, this is the correct answer. There is no arguing with this. This is the correct answer. This is not tricky. So if you get into a situation where you just don't know the answer and you're trying to sit here and figure that out, again, go through the process. Do I understand what the question's asking? Am I missing something? And of course, if you see 3 very correct answers that are equally correct and 1 incorrect, you've missed something like all the following are true except, or which one is not, or something like that. But if you find 2 very correct answers, then it is something that you have to do first, or it is the better choice in what you do for that patient. I couldn't tell you how many students, on close to final exam for EMT always miss the important question. You have a patient that was stung by a bee, having difficulty breathing. There's hives. He's feeling like his tongue is swollen. What's the first medication, life-saving medication this patient needs? Oxygen. Everybody wants to jump on epinephrine because that's how you treat anaphylaxis. Didn't tell you it's anaphylaxis, but they described anaphylaxis. Scenario-based question, just like registry. But what was the first clue on oxygen? That is the very first clue on it, because you have a patient with difficulty breathing. What's the first medication they get, et cetera, et cetera. All right, so just remember, time, you have all the time in the world to do that. And those first few questions that you think are absolutely ridiculous and stupid, spend extra time on it just to tick the computer off. Because what that computer is doing is saying, how smart is this cat? How smart are they? And if you're really smart, they're going to nail you to the wall on question number 8 or 9 when that gate is open. And if you're not all that smart, I'm telling you, pretend not to be. It's going to be very methodical to it. I had 2 cardiology questions. I had a 12 lead and a something like a VTAC, and you had to do different. Is what we're spending a lot of time doing. Oh, get alert here. I don't know what that means.
nice chat.
Oh, okay, good. They can do that. So the important part about it is just be patient, take your time, go through it, just like the requirements for this class. So I'll go ahead and move on. So, and of course now it doesn't want to work. That's where it was. There we go. All right. So you got to know the knowledge, the materials, and that's why we're here this weekend. Is if you're here just for your hours and everything, it's just the essential information that goes along with it. I've already told you how to work. I've already told you how you get it. I've told you a little bit about the ability to take it and test it and everything else with it. Basically, the computer has to figure out that you're qualified to be an entry-level paramedic. It doesn't care if you're the best paramedic in the United States. It doesn't care if you're the worst paramedic in the United States. It just says minimum standard for being a paramedic. And so you've got to hit those questions. You don't need to let them get you torn up. You pick the best question or the best answer to that question, and you simply move on. This is a analysis of the difficulty and the number of questions, and basically, as you get to that tail end there on the right, should be smooth sailing as it starts to detect that you're a competent medic. And towards the end, I would expect to see lots of questions on Guillain-Barré, myasthenia gravis, Addison's crisis, and you're just going to get one after the other, after the other, after the other, and you're thinking, where does all this come from? I don't remember this except from school. And so that's one of the things we're going to cover today, and so some of that material that you don't often see with it and everything. So can't skip questions and come back. I already told you that. The next question to get delivered is based on how you answer the previous question. That kind of stinks. North Carolina used to always be terrible about that. They said, you know, if you miss this one, it might indicate that you missed the next one as well. So again, a scenario-based question. It may give you a couple of questions based on that scenario. Now, that scenario doesn't disappear. There's just another question tacked onto it when you move on. So other little simple things, they give you a dry erase little board when you start, all those little equations and formulas and things that you don't do before. Go ahead and write them down and sit down, because you're going to forget them in about 5 questions. Go ahead and write them down, Parkland, all those formulas, stuff like that. Write them on a little dry erase. Any little helpful hints that you want to, your cranial nerves, anything like that. You may or may not see it, so be all right. I already told you that about this. This is so important to know that I couldn't tell you how many places I go to and people are screwed up by their local protocols and they want to argue, and then they get mad because they failed static cardiology at Registry or something like that. We had an entire class come through one place, and the entire class failed, and pulled everybody in here. The first question was, do all of you know each other? And they say, we're all in the same class. Like, okay, good. And it was over, it was over atropine. And they said, what do you do for symptomatic non-perfusing bradycardia? And they all looked at each other like deer in the headlights. And then one of them said, well, our instructor said they didn't care what AHA said in his vast years of experience, that you always go straight to PACE. And the lady with Registry said, well, your instructor got you all failed. Thank you. Have a nice day. This is National Registry, not your instructor's test.
And failed the whole bunch.
Well, they failed. They failed themselves.
Yeah.
And how they learned it. And it's very unfortunate, but you cannot argue with American Heart. You can't argue with National Registry. So for some people, you have to unlearn it temporarily to go take the test and do the stations. You just have to. So it's not anything that's controversial or anything, but I've always said, if you take your AMLS, your PHTLS, your ACLS, and your PALS or PEP within 3 months of testing, you pretty much got the gist of a majority of that exam, believe it or not. And that's why for renewal, I mean, it's just, those are your hours, just period. So airway ventilation, respiration, trauma, cardiology, and resuscitation, that is its own individual thing, even though medical emergencies and most texts are considered, cardiology or heart attack, all that kind of part of it. But that's just such a huge section. Medical and OBGYN, those were a number of questions. Anything and everything are pertaining to that. And of course, EMS operation. All right. So this is a good realm of possibility. And again, if you look at that spread, it's an estimated of they use. You're looking at 26 to 30. So it's a good time to know. That's probably Glenn or somebody working and doing something. It's a good thing to know that 85% adult, 15% pediatrics in each section. So when you have trauma, you're going to have pediatric trauma. Cardiology, SVT, you're going to have pediatric SVT or something like that, as well as airway. So just remember, you can't run it and hide from peace, whether you like it or not. Again, I'm going to be very straightforward and fast on these. Lots of resources that they use it from. The questions we talked about it. Always the best answer. Watch out for those words that we said. I already pretty much told you this. And then we have a couple of practices here for you. Always those distractors. I come back later to those that are testing for this because I don't want to kill everybody with death by PowerPoint today. Signs of criticality. That's always good for anybody because that's that whole stable versus unstable patient. It's that way with ACLS. It's that way with your cardiology for registry. So when you look like things, look at your perfusion status. That's always a big hint for things like that. Don't read into anything. There's no tricks. You may think it's a trick. It's not a trick. It's just, it is what it is. It's a question that a lot of people have looked at. It's all good. It's just time to move on. If you don't know it, just like what Anna said, little tricks of the trade. The longest descriptive answer sometimes is it. And it's often B or C. Very seldom and rarely do you run into, I mean, there's A's and there's D's all day long. But if you don't know, you're able to rule out one or two, just go with that gut feeling that you have about it. Quite often you're going to be right. But I mean, you get it down to two answers, you have a very good shot at getting it correct. Don't assume anything. Don't read into anything. In other words, if they are talking about airway management and they're talking about getting a CO2 reading, and one of the first answers is, make sure the tube's in the right place before doing that, you think, well, you probably should do that. Well, if you're at the part of doing CO2, you already know it's in the right place, and it's all good. You don't have to go back in time for certain things. So just remember that. Always said, just, read things carefully. Pay attention to what's asking. We already talked about this, studying the right stuff. So give you short scenarios, they give you that information. There's no tricks to it. So use current practices with American Heart, National Academy of Pediatrics, orthopedic surgeons, all the people that write the books. That's the stuff that you got to. Like I said, for the practice tests like in this class are very useful. Maybe after today, maybe after this little brief talk that I've given you, your practice test will be a lot different, and I would hope it would be. So some of the things about it, I'm trying to do. So define strider. That's a very straightforward, to the point question. And then here is what you will see like with registry. Significance of patient experiencing stridor. So like you go back to your old state test or your class test, this is a typical question. That's a good question. But everybody knows that. Registry is going to say what's important about it, or what's significant about it. There you go. All right, so let's take a couple of stabs at a couple of things. Patient fell while skateboarding and has a painful swollen deformed lower arm. You're able to palpate the radial pulse. You should immediately. So what is our question describing? Somebody take a stab at it. What are they describing? Broke arm. And then what's the criticality of the question? No pulse. No pulse. And what are they asking you to do? What should you do now? Exactly. And so, what do you guys think? No, you jumped on it real quick. That's quite possibly the correct answer. Anybody else? Which look at this question. This is a great example. Which is the one that's just out there, the wrong answer? No, A's actually something you could do. D, ask the patient to try moving it. And some of you are saying, well, you would say wiggle your fingers. That's not moving the arm. So moving the arm is probably the one that's far out of there. Splint the position found. That's pretty good, right? Okay, that's what you do if there's a pulse. say, well, it has in the question swollen. So is a cold pack okay for swelling? Yeah, sure. A good little thing to remember on that's the word rise, R-I-S-E, for fractures, dislocate, all that stuff. Rest, ice, cold pack, splint, and elevate. So rise is always good. So applying cold packs would be appropriate. It doesn't say ice packs, it says cold packs. So, always get on to people about that because they always say, well, you're not supposed to put ice directly in the skin. It's not ice. It's chemical cold pack. So
What did you say? Rise, Kim, say it again.
rise, rest. In other words, get off of it or stop moving it. Ice, splint, elevate. And of course, ibuprofen if you're not going to have surgery. So he's correct. It is align the arm with gentle traction. Why? Because we have loss of pulse to that. So yeah, absolutely. So your patient, this 26-year-old man with a history of terminal brain age and a pre-existing condition. Your right hip pain. Okay, well, call 911, putting him back to bed. Says the DNR orders transport, does not want him transported. This is a question like this you will see. This is your operations section. It has nothing to do with the medicalness of this. So, what do you think? And again, this goes back to what would a competent paramedic in the United States do? Now you go to ethical. Now you go to, what does a reasonable and prudent person do? It's a legal term. Has to see the DNR orders. Does he need to be resuscitated? Number one. So why are we talking about DNR? All right, move on. Explain why it needs to be transported. Is that not a logical thing you would do? Okay. Have her sign a refusal form. Does it say anything about her being the medical power of attorney? So you're looking, it's not in there. They didn't offer it to you. It's not there. It's not really correct. Oh, that's wonderful if this was an abuse situation or something else going on. Is it? Doesn't really pertain to this question. So by default, whether you know the answer or not, correct answer was that. So it's more of an ethical thing. Call the scene where police had detained a man they thought was intoxicated or drunk. They call you because he has a history of diabetes. Okay, so they're doing a good job. They're saying, hey, this guy's, we want to make sure you administer oral glucose. Within a minute, the patient becomes unresponsive. Now, I know you're thinking, well, why didn't you check your sugar first and all this kind of stuff? So you need to ask yourself, if this person truly is diabetic and they're altered. Let's look around the room here for a minute. So, Coca-Cola. How many grams of sugar are in that? How many servings are in there? One is one. That's the serving now. A couple of years ago, that used to be 1.5 or 2 servings in that, and it was 48, and it was times the 1.5 or times 2, so it's about 65. Okay, so 65 grams of sugar. Is that what you said? How many grams of sugar are in anti-50? 25 grams. Do you recall in the history of the United States anybody dying after consuming half a bottle of Coca-Cola? So, moral of the story is, whether he needed the oral glucose or not, did you likely cause him to get worse? Okay, so you should. What do you think? Let's go through them. Remain at the scene under police authority and request ALS backup. That doesn't really matter. Leave the glucose in place. Complete an initial exam and transport. Open the airway with OPA, ventilate. Okay, let's just push that gel on into his lungs. Suction the glucose out of his mouth and begin transport. By the way, magical clue here for patients like that. If you take an airway class, I hope they would cover this. How do you know somebody can protect their airway? What is the one thing they can do? That's a good one. It's not 100% though. Well, let me rephrase the question. What can you ask someone to do? that you know they can maintain the airway. I have low blood sugar, I'm altered, I can't talk to you, but I might still be able to follow commands. In every case of people that can maintain their airway, whether you ask them to or observe them doing this, yeah, you saw that from across the room. So if you have that ability to swallow, you have that ability to protect your airway. So if you ever ask about little sips of orange juice or oral glucose, then yeah. Realistically, would you have placed enough in this mouth that you have to suction out, or would you give them a little bit at a time? That's not the question. That's not what they're looking for. They want to know the process of what you would do in that situation. So yeah, that's the answer. Suction it out and transport the guy. Woman brings her 18-year-old son to EMS station. Patient's actively seizing, according to the mother, has been seizing for the past 10 minutes. States her son's history of seizures and takes Depakote. Patient cyanotic is breathing erratically and has generalized muscle twitching to all extremities. So is he still seizing? Okay. You should. What do you think? This is always a tough one. People always have tough one with this one medically. What? You have two questions on here that basically go straight to what? First. What are they telling you to do first? Or two answers, I'm sorry. We have two that, you know, and this, do remember, when we're not talking about CPR, and this is not a CPR question, when you're not talking about CPR, airway, breathing, and circulation are always first. So ABCs. So you have two that directly go to ABCs. We know he's probably in the front seat of the car. We're not as concerned about restraining him or you know, further injury, and you're not going to restrain him anyway. The bite block, you know, shoving the spoon in their mouth, that instantly kind of killed that answer. I mean, I'm still going to read it, but you know, see where it goes. And then what was the kicker for a C? What was the one that kicked it out? Yeah, hyperventilating with a bag valve mask. And so, not really by default, but you know, the most practical answer is airway, ventilation, IV, and then take care of the seizures. Well, how do you take care of an airway on somebody that's actively seizing? The best you can. He's not breathing well. He doesn't when he's doing that. So you gotta have to just kind of do the best you can. 51-year-old man complains of chronic headaches, worsened progressively over the last 3 months. They called 911 because this headache is severe and he's nauseated. Vital signs are stable and he's breathing adequately. The patient denies any medical problem, stating he's been taking acetaminophen for his headaches. Should be most suspicious for. All right, so keyword there at the end, most. They've given you a wonderful history on this, sort of. Do you have signs and symptoms of sinusitis? No. So I'm pretty much saying we're not even talking about that. Do you think you're going to be, you know, that's a good nurse practitioner, PA, doctor question about sinusitis. Do paramedics usually typically treat? Yeah. So just think about it. All right. What do you think? Huh? It's okay. We can all be wrong. I'm going to tell you why the answer is correct. Remember what I said about test taking 101 about your answers. Why do you say B?
A, that's what my gut's telling me. B is for 3 months, he's not going to have a ruptured artery for 3 months.
Right. It's just about impossible. So let me ask you something. What's a hemorrhagic stroke? What does a ruptured cerebral artery do? So since those answers are identical, can it be those two answers? So what's the answer? And why is it that? Because of the progression. It's as simple as that. All right, elderly man and resident of skilled nursing facilities found unresponsive by staff nurse when needing partner arrived. Says the patient noted respirations are slow and shallow, his heart rate slow, weak, irregular, skin's cooling, clammy. You should. What are you thinking? Checking the sugars is extremely important. But go back and read the question. He's unresponsive. Respirations are slow and shallow. His skin is cool and clammy. They have painted you a picture of this patient. And you know beyond a shadow of a doubt that he probably has hypoglycemia or something. Yeah. But is that what you do first? Take care of the breathing and oxygen because his respirations are what? Yeah, there you go. Y'all get this. All right, good medical. Because the facial nerve is not because it stroke is the right cerebral hemisphere, most likely cause what? Which one? I heard somebody say it. Which of the following cranial nerves regulates movement of the head and shoulders? This is one you either just know it or you don't. This ain't a guessing one for registry. You just can't. If you remember the terms for it, which I'll show you here in a little bit. Why? Another good way to think about that one is because of it being accessory. You know, I always think about accessory as non-fundamental of life function kind of thing. So accessory nerves, the ability to do this. Or you can say, I don't know. So that'd be a good one. Head and shoulders. Peripheral nervous system, what's it responsible for? I'll go ahead and throw the answers up here. This is the nice thing about the you know, I can ask you this and it's difficult for you to throw the answer out, but if I threw out four answers, you start the little process and you're going to start figuring this out. I heard one say D, I couldn't hear you. You said B. Peripheral nervous system, so it's the inside that. Just remember your periphery. The stuff towards the outside. Sensation, so sending and receiving. Feeling is the partial correctness to B, because I heard a couple of you say B, but then when you throw in autonomy to it, that rules out peripheral to it. Then you have motor function, which is a portion of it. So it's challenging, but if you sit and think about it, this is a very simple question. All right, here's a long one. Residents, middle-aged woman, generalized weakness, 18 hours. Primary assessment reveals right-sided hemiparesis, left-sided facial droop, bilateral equal reactive pupils. Further assessment reveals blood glucose level is 70. On the way to the hospital, increase movement to a right arm. Receiving O2 and has IV in place. Which of the following statements regarding this scenario is correct? Why'd they throw D in there?
Because it's also something.
Kind of, sort of.
70.
70 is your borderline. Now, look, you have hyperglycemia all the time. 70 could be low for you. Okay. What kind of facial droop? What kind of hemiparesis? So do you have a sugar issue? Okay. All right. So, or possibly. So what did you guys say?
Get in that.
Let's go with C.
Whatever.
And why is it saying that she has a TIA? Things are starting to get better, so it's resolving.
I can stand
But what should you do?
Yeah.
Still treat her as if she's
Way out here
having
in
a stroke.
the
Absolutely.
Okay.
And this is not a treatment question, by the way. This is what do you think? Who wants to be a paramedic kind of question. And so you have to look at it and say, what's in the best interest for this patient with this. And if you say the answer is D, and if you want to argue with that one, then every time you have a stroke patient with a blood sugar of 70, you have to, by your own statement, give all those patients X-rays. And so this is one of those times you have to say, what do I do every single time for this patient presentation? That'll help you a lot, because a lot of these questions and scenario-based questions, they will go into detail about, well, you could do this. You could say to yourself, you could do this. Well, if you could do this, you have to be able to say, I would do this for every single patient that presents this way. If you cannot say that, that is not the answer. All right, a couple more and we'll take a break. Arrived at the scene shortly after a 7-year-old girl experiencing a seizure, according to the child's mother, sitting at the dinner table, and suddenly stopped speaking, started blinking her eyes very rapidly. Episode lasted less than a minute. Child got rapidly better, improved. What's the clinical presentation consistent with what type of seizure? And of course, they have kind of tweaked seizures a little bit over the last couple of years. All the textbooks have changed a little bit. So, absence.
The grill. Okay, that's enough.
And what's the, what are they calling that? Absence is pretty much the definition now, but what did they used to call it? Petite mal or sometimes partial motor or something like that. I don't know. They're cutting it down to just a couple of names now. Yeah, absences for that. All right, let's do this and we'll take a break. Assessing an unresponsive 66-year-old man in history of 2 prior strokes. According to the patient's wife, he complained of severe headache and then passed out. Respiratory effort is poor. Blood pressure is elevated markedly. Pulse is slow and pounding. The glucometer reads error. You should. This is a tough one. This is also one I'm going to tell you after we answer it that killed a lot of people in one of the scenarios for registry before. Read every answer in its entirety and pick the best answer. All right, who's got it? I heard one answer. All right. Heard another answer. All right, let's talk about it. High flow oxygen, is that okay? That's totally fine. Cardiac monitor, is that okay? IV? Sure. 0.5 of atropine. What's the problem with atropine? They don't give you a numeric on his vital signs, or will they tell you about his vital signs? Pulse is slow, but what about the blood pressure? So is he perfusing? We already had this discussion. Do we need atropine? Okay. So what is the only condition that you have where your pulse is slow and your blood pressure is up? it is prevalent in trauma, to certain types of trauma. What is it called? Cushing's. And so what's the cause of his bradycardia? It's heart. ICP. And so he had complaint of a what? Yeah, do most of your diabetics before they pass out complain of severe headache and have a history of strokes? Okay. So what do we go with our correct answer now? Hyperventilate with a big bag valve mask? Well, that instantly tells you that is an incorrect answer. What would be appropriate if you wanted to get rid of some CO2 or something on any other question for registry? What would be appropriate statement to say other than hyperventilate? No. Even simpler than that. Just think bag valve mask. What's the terminology I'm used? Increased ventilation. That's all they're going to say. They're not going to say hyperventilate. You know, most average adults breathe 12 to 20 times a minute. Increased ventilation just means you're at 20 instead of, 14 or 16. And with a bag valve mask and O2, you don't need to typically breathe any patient very often anymore. So the correct answer would be assisted ventilations, apply cardiac mask or an IV normal saline, administer that, and then go ahead and reassess the sugar, or not reassess it, or assess level of consciousness. So by default, you've got all these issues going on. Is that going to kill this person? Who's going to hurt the person? But all the other things are problematic. And no, I don't like that answer. You may not like the answer, but
It's quite the best of the others. Yeah.
exactly, you got to thin it out. All right, everybody take a little break. Let's take 10, get up, move around. If you want to go outside and yell and laugh, that's okay too. Especially over by those guys that are working. I'll cover that. Just sitting there ready to get well. How is she? How is she?
Oh, good. It didn't just make me upset. Like, well, this is not warm. Like, I know it's warmer outside now.
He's good.
Yes, sir. How old is he now?
He'll be 6 in May. Started in school, lost his first tooth.
My son will be 23.
He hit that growth spurt. He's all arms and legs. He's so scrawny. All that baby fat's gone. Dimples in his hands are gone. He's finally got an arch on his feet. He's about. That's all, man. Yeah, I know. It makes me feel old. Does she? I got a job at Henderson EMS in Hendersonville, and I like it up there a lot. First day up there, I'm on their truck, and they're showing me all their equipment. I'm like, in an EMS trade show convention, I got dual line pumps on the truck, X series monitors, ESO software. I was like, holy hell! And plus, I make about $19 an hour. Well, yeah, and you can work as much as you want, and everybody's super nice. There's no bitching, there's no pissing, there's no moaning, none of that. And I'm like, the hell? I don't know what to think.
You know, David said that Randy was different now that he was nice. Starts to his own church.
Totally different. When I was running Medic 10, he only called me and cussed one time. And then he came down there 20 minutes later and apologized. He actually said he was sorry. He says, it wasn't you. He says, I was mad about something else. And I just took the brunt of it. I was like, oh, okay. Like the Medic 10 phone, he'd only call me on Sundays if I was working. It was always, hey, what you doing? I'm at work. Oh, but I just want to call and check on you. Everybody show up. And I'm like, yeah, everybody was here on time. You got no truck? Yeah, well, if you need something, call me. I'll be around. I don't have a radio on, so I'll call you, text. Go call Kenny. You got Shannon's number? Hold on, I'll be Kenny. Come give him your number. I did too. Kenny has those. You got 5 brand new trucks,
My
monitors,
thing
new
is,
computers.
that would be a truck done, and I can't afford to spend that much money on a truck.
We got the X series monitor.
When my Madden number says in the
Yeah,
house,
so that was my other one. Doug was like, I'm really looking at Phillips.
45 to something, and Madden on the truck.
Just get the X series, easier to work, lighter. You use one battery versus 2. That's a whole lot more durable. We got some nice
So
laptops.
nothing right now. She,
It's a different kind of play. Frank's got her medic. Marshall got her medic. Swing got his. Jeff Swing.
I know, Marshall,
Yeah, quit worrying about it.
Whichever one she wants to have, or trying to-
Frank got hers about 2 weeks ago, and then she's been riding with me. We're working on that. She's passed the skills. We gotta get her past the written.
Bad thing is the blue line block.
I took it twice. First time it cut off at like 70 meters. The second time it went all the way to 148. Stop. First time I thought I got it. I passed it. Failed it miserably. The second time I was like, no, I just failed, and then I got that congratulations. Oh. I think most expensive thing that plugged in.
Drinks are
Drinks are $25, but they got the card reader on the drink.
Completely different. Completely. And we started off as the same round, we don't end up as the same. And a buddy of he's had some problems. A buddy of mine was a block. 43. So it'd be looking at 43. Yeah. My buddy just got like 5 or 6. It's been the first round. Have you had any dealings with Assurance Arms up in North River? Don't. You know Jimmy Gennaro? Jimmy went in, I think it was a block. I don't know exactly which one it was. I think it was a 41. There was a waiting list. Jimmy paid his money. They called him, said, your gun's here. Well, he was on his case, so I got there until this day. When I first hit the gun, they sold it. And he's the blue line dealer for the area.
At the 43 is up in,
Not the same, no.
yeah, okay, how much is it on the blue line?
I don't know. I gotta find out. I know what I want my next one to be, and the way I'm getting told is, no, maybe. Yes, dear. And so,
Yeah.
He's got
I'm working real hard at
I probably wouldn't know anybody there.
Springfield SD Mod 235.
pretty much the only ones you probably know would be
I
me,
carry-
Levi,
I carry
Frankie,
people.
Marshall, Christina, and Chip.
All right, well, that absolutely messed up that by hitting play again. Go back to where we were.
Tim Bailey came over from English Star.
There we go.
No, Tim is the heavy gay guy. Mary's.
All right, so I had a interesting question during break, and it's awesome that dementia has already set in. I don't remember what it was. Oh, I do remember now. It's great. Calculations. Somebody was talking to me about calculations, and another thing to remember about calculations, there is no 3 a.m. rule for registry. You do correct dissemination to kilograms, and then you do an exact calculation. And that is where you will find your answer. They will give you the shortcut answer, by the way. And don't take it, because that's not the correct pounds to kilogram answer. So when you do your conversions, do them long-handed, do them on that little dry erase thing, and just be done with it and do it every single time. Like I said, you're going to have plenty of time to do it, but do it right, and that's where you fall into. They got me on dopamine. I did my calculation 3 times, and I kept getting 30. That was the answer I kept getting, was 30 every single time. Did it a 4th time, got 30.12 something. The answers were 35 and 25. So I had no no room of error on what to move my calculation to, and I chose 35 because the last time I did it, I ended up with slightly over 30 as my answer. I was wrong, of course, but that just shows you how precise it is and how well you have to know it. All right, so how did we end up here? Okay, all right. Here's another of the headache type questions. One of the things you have to remember with that is, and we've done this, we've danced around this whole time without actually saying it, but differential diagnosis. And that's where all these things fall. You get it down to two answers. You have to figure out what the differential is on each of these patients. And a lot of it has to do with perfusion status, like I said, on your cardiac questions and everything, whether to, like with your SVT, whether to get the person to vagal down or whether you try medication or whether you cardiovert. It all is going to depend on that scenario and the information they give you. Sometimes it's very subtle, but if it's there, subtle or not, it is still there, and you have to go by whatever that is. So you're dispatched to a resident for a 44-year-old woman with severe headache. Find a patient lying on the sofa with a wet washcloth on her forehead. That's a very common picture. Everybody can relate to that. Tells you that has a history of migraines. This is one of her typical headaches. She also complains of nausea and photophobia, which is what? Light sensitivity. So here's another good thing about Registry. They will often use terms that you may not have heard in a while or even heard at all. And quite often, I'm not saying this is one of those questions, but quite often, that's the thing that makes or breaks you. And if you don't know it, it's a problem. So blood pressure, how is it? It's high. How's her heart rate? Yeah. How's her respirations? So all, her vital signs are up, but everything's else pretty good with this lady. What are we thinking? We created this answer first already? Let's look at the answers. Because like I said, this is not one of those classes I get to mess with you the whole time. You actually get to see the answers when you do Registry. So assessing your pupils, oxygen, starting IV, morphine, and transport. We don't usually do that for migraines, do we? Okay, then don't do it for this one. Fowler position, O2, transport to the hospital for definitive care. That's reasonable. Oxygen is tolerated. Starting an IV, administering what? Lofran, transporting without lights or siren. Not bad. High flow oxygen, vascular access, nitroglycerin for the blood pressure. Yeah. So let's talk about this for just a second. What's wrong with her? Everybody tell me, what's wrong with her? And she's having a migraine, okay? But as a paramedic, what's the worst case scenario? Stroke or head bleed. We're saying, really, it's the same thing. So, yeah, she's having hemorrhagic stroke or she's having a migraine. One of the answers in there is going to be the least detrimental for what you don't know is what's going on. C. Absolutely. You're not going to hurt anything with that. You're going to fix some things with that. You're going to continue to move on. 33-year-old woman has an apparent syncopal episode. So now we get into the whole differential. Why would somebody pass out? Or her husband complained of dizziness before the episode. Okay. Caught herself before she fell to the ground. Why is that pertinent? Let's not go down the whole road of do we need to immobilize her and all that kind of stuff. She's confused and sitting in a chair. Blood pressure is, how is it? Oh gosh, is it low? That's the magic number of perfusion. It's not great. It's not low. But what are they trying to tell you here? She's perfusing. Move on. How's the heart rate? And it's weak. Why? Respiration is 22 and regular. Blood glucose is 74. What is this?
Apparently, sometimes between 8 a.m. and like that. You have to call about and have these.
Okay, so you Yeah, you're going out on a limb there, and that's possible. What's likely about this? Where is she? Where is she right this second? Sitting in a chair. And what's her blood pressure now? What's her heart rate now? So, doesn't really have much history with it. So let's talk about it. Is hypoglycemia? It's not. You've got it documented. Vasovagal response. Was there any conversation about her sitting on the toilet or having something episode or anything like that? Okay. Seizure. Any description of that? Not at all. So not a single person, including myself, would have instantly jumped on dehydration as part of it. But what do you think is going to happen when she gets out of that chair? Yeah, and they don't give you any of that, but they hint around it. So this is a typical paramedic differential diagnosis type question. Is you have this information before you. You're not giving anything about her intake and output. So now you have to figure out all the other answers, which one's more feasible. Yeah. This presents with dyspnea or crackles to all lung fields. Creative parts, calling conventions have the most immediate. What else do you guys think? I'm not saying it's wrong. I'm just saying. Thank you. Because it's not saying what you do first. That's what the question's asking you. It's saying, what do you think in your tools in your toolbox that you do is going to have the most effect on this patient? It's not saying you should immediately do this, or what is the first treatment you should do. What does it say? It's asking you a specific question to you. It says, which of the following interventions, we're not even talking about what we're doing first, what we're doing last, or where you're taking them, will have the most immediate and positive effect. Immediate and positive effect. A lot of these things are things you're going to do. You're not asking that. So if you've already said, well, a lot of these answers are correct, that's true. Back to the question, most immediate, and that was the first answer that I heard. So basically, what are they saying in this question? They didn't come right out and say it. What are they talking about? This patient's going to get.
To me, it's what's going to do the most good.
Right, but what are they talking about without spelling it out? What device are you going to do? CPAP. That's what you're saying. You yourself are going to say, per protocol, we probably start this patient on oxygen first, and they probably get some nitroglycerin and all that. All that's wonderful, and that's in the correct order. However, it's asking you, of those things, what's going to have a positive effect for this patient? Talk about crackles for a little bit, because I hate that term. Crackles usually refers to what? It's a broad description of airway sounds. It's not. Okay. What true sound did this patient have? The patient had rales. Okay, rales is usually defined as what? Fluid. It's fluid. What's wrong, Kai? They call it coarse. Sometimes they throw in crackles with that. What's wrong, Kai? It's wet as well, but not as wet, and it's thicker. What are they describing? Pus, infection, pneumonia in the lungs. Okay, what's wheezing? Now here's where we run into a problem with our differential. Since we're talking about respiratory. Here's your airway passage. Typically with wheezing, we associate that passage gets narrowed down to about that size. Right? That's typically what we think of with wheezing. Okay, what's the other problem? And asthma is a good thing, so we'll talk about asthma. What's the other airway restriction in asthma? You have restriction by spasming or reactive airway. What's the other problem with asthma? So what? What's the other physical property? Constrictions, well, I just drew. What's the other constriction that happens? No? That's all the same.
Okay, sorry.
It's okay. Nobody in here has asthma. or if you do, you have restriction. Increase in mucus plugging. Okay. So
I should have thought of that. Because
increase in mucus production. All right, so everybody, there's a little test that we're going to do. So everybody open your mouth real wide, say "ah." And while your mouth is open like that, whistle. Okay. All right. So how do you whistle? What happens to the airway? It goes from that to that, which allows you to make the whistling sound. So let's talk about the whistling sound. We said restriction is one of it. So here's that mucus plug thing. Can that wheeze? Okay, so we've got two forms of asthma that can wheeze.
oh, so that's cystic fibrosis.
That was a chunk of mucus. It wasn't
I mean,
understood.
but the mucus production.
Oh yeah, gotcha. And it can wheeze as well. All right, so what else can wheeze? We said Strider can, but that's upper, and it's restriction down here in the presence of anaphylaxis. So what else can make this thing wheeze? It should look like this, but it doesn't. Yeah. So we hear rails all the time as air goes through it. As they start to get real tight and you lose surface area, diameter, you have that narrowing of that passageway. And what's that medical term called when you have rails, but it produces wheezing? And, you know, North Carolina is a pretty progressive state. I like that. So if you look up in their difficulty breathing protocol, you'll actually see it. But what's that term for that called when you hear wheezing in the presence of fluid? It's okay. Nobody throw your answers on. It's okay. I'm at a disadvantage. You're at a disadvantage with me because I know what I'm looking for. You don't. My dad used to do that with tools in the garage. He would say, "Hand me the whatever, you know, spanner wrench or whatever." And I'm 6, and I'm like, no, I'll just get it myself. He could see it. He knew what it was. I had no clue.
So which protocol?
Probably under pulmonary edema, difficulty breathing. So you don't have to look it up. But there's a term called cardiac asthma. And you hear it from time to time. But that's what that is when your wheezing is coming from fluid. Why is it called cardiac asthma? Because pulmonary edema is not a lung problem. It's a cardiac problem. It's a back pressure. It's not able to get circulation out kind of thing. It is not a respiratory. It presents as respiratory distress, but it's not a respiratory issue. All right. So with those sounds, you've got lots of things moving around. Of course, you have chunks of, you know, pus moving around and everything in there. That's what gives you your rhonchi. And then we talked about, from that presentation question, it talked about crackles. And crackles are greatly defined by lots of physicians, even pulmonologists and everything, as a loose term of, you know, do I hear some fluid? Do I hear some pus? Do I hear some whatever? Do you know what crackles were originally supposed to be? What's the disease process in your lungs where you lose the elasticity, the hardening of the arteries, so to say, of your alveoli? COPD and emphysema. And so when you have the term crackles, and then you have your alveoli, and that's a healthy alveoli. And then when you have, sorry smokers, they exhale, and they retain all that CO2 because they don't have the ability to get rid of it. And well, what do they call them? What's the one thing they do in that description? We used to call them the pink puffers. And because when they exhale, they always do the, I'm not blowing kisses at you with my nasal cannula. Why are they doing that? Exactly. They're trying to have that end expiratory to try and get that extra little thing out. They're already using accessory muscles. You're just not paying attention because they're doing it every time they breathe. What happens is when they take a breath, these things that look like that, suddenly, what? Because they're not elastic and they don't retain their shape. They pop open when they take a breath, and when they breathe out, they pop close. And that popping open and popping close is also what's known as crackles, because it is a continuous pop, 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 and you're hearing that everywhere in there, and that's where you hear crackles from. And I'm not here to pretend to be a doctor or a pulmonologist or anything like that, but use terms in the way they're supposed to and understand where they come from. And like with that patient, you know, with that scenario, crackles, it's a wet in that instance. But how do you describe this when you hear that? And that's what crackles are. Can this person in these passages go from that to that because of the other issues? Sure. And that's where you get the wheezing among with it. So it helps you to figure out, do I need to give this person CPAP? Do I need to just transport? Do I avoid fluid? What do I do in this situation? And it's all about, you know, this morning it's all about looking at the information that you're given. And it's very limited in these questions because you can't say, you know, like with the lady sitting in the chair, we didn't ask if we could sit her up. We didn't ask if she got lightheaded when she stood up. It just says she's felt lightheaded several times and she did this and she did that. And so after that, you sort of have to pull from it. And so that's what all about today is just pulling from it and making it figure out. All right, so your says in a 12-lead tracing. So here we go into our cardiac of chest pain, ST segment elevation in 2, 3, and AVF. B4R showed 2 millimeter ST segment elevation. What are we talking about here? Okay. Right, so what? What are we talking about? Okay. Patient's blood pressure is what? 2 little points below optimal perfusion. How's his heart rate? We're good on that, so don't worry about that. Denies any significant past medical history. Allergic to salicylates. So in other words, yeah, after placing the patient on oxygen, starting an IV normal saline, you should what? Let's see. So is number A or letter A out? And if you're not familiar with, you know, and this is one of those terms that, you know, because instantly when I looked at this, because I just had this class yesterday, I looked at this and I got salicylates confused with phosphodiesterase. And that was in my mind. So make sure your mind's clear about what's what and what's where. So yeah, aspirin type. Morphine. Blood pressure's not great and you want to, you know, okay. So dopamine. Blood pressure's not really necessary for it. He's perfusing. Okay. Yeah, we want to, you know, once you get that pressure to a decent little place, and it says boluses or give crystalloid bolus to increase preload, improving that pressure. Yeah, that's always our concern when we were talking what? Right-sided, absolutely. So you don't have to have a magnificent knowledge of 12 leads and ACLS and things like that to deal with that. Just understand the fundamental workings of it. But number one, you knew A wasn't the answer because of the question. The morphine and the blood pressure didn't really cohabitate well. And it wasn't great enough for dopamine. So you really didn't have to know what in the heck this question was talking about to figure out that D was the correct answer. Refractory period. Oh, here's one of those questions I hate. Number one, I can't tell you. I don't know. I could have read the whole book last night. Today, I don't remember. What are they talking about? Refractory means it's redoing something. Don't spend too long. Again, this is one of those you either know it or you don't, and that kind of stinks about it. And you'll see a question or two like this. They're very short and brief, and you think, oh, this will be simple. It is. You know what it is. Depolarizer process of repolarize. Which conditions usually cause the blood pressure to vary between the left arm and the right arm? So we can think about that. There's lots of conditions like that, actually. I don't remember what A is, I'll be honest with you. Remember that from the book? I know what B is, I know what C is, and I know what D is. Here's where our confusion lies between B and D. Left heart failure leads to pulmonary edema, and it really doesn't have that too much effect on the different pressures. So B or D, which one is it? It's B. The AAA, or the aortic aneurysm, causes the difference between the left arm and the right arm. What does D cause? Yes, because of the narrowing of the two. Doesn't cause a variation between the one side or the other. Causes a narrowing pulse pressure. So here are one of the things that you should know. Again, we talked briefly before about Cushing's triad or Cushing's reflex. Actually, we didn't talk about the triad. We just said Cushing's phenomenon or Cushing's reflex. The phenomenon is that the blood pressure goes up, the heart rate goes down. The reflex is because the blood pressure goes up, the heart rate goes down. What's the triad in cardiac tamponade?
Heart's working harder, probably getting pumps.
What's it called? Vex, correct. And what is the 3? Pulse pressure, because Anna already said so. JVD. And distant or muffled heart sounds, correct. What's the 2 causes of cardiac tamponade?
You got bleed?
Well, okay, let me be more specific. There's lots of reasons you can have blood in there. Trauma's, the major one that can result. But what's the 2 reasons of cardiac tamponade internally? It's either blood or it's no, not around the heart. Kind of fluid. You want to say it? Come on. No. You're on the right path though. Why would you have what kind of? You don't have saline just here around the heart.
Just us.
There you go. Thank you. Pericarditis. And the cardiac tamponade is easy to figure out in the field with that. You just can't really treat it. What was our effective treatment 20 years ago? And it never worked. Why? Because by the time you find it, what happens to blood that sits somewhere that doesn't move? And you stick a 14 gauge in, it's like going, I always tell people, it's like going, in the old days, the hospital cafeteria, you had to eat there, and you have that red thing of Jell-O on top with a little dollop of whipped cream that was hard and cracked on it, had been there a couple of days covered in saran wrap. Try to pull that through a 14 gauge, and that is what is like blood sitting in the pericardial sac when you're trying to do a pericardiocentesis. If you are there and on the spot and you can pull it out, great. You need to find it. What happens when you pull it out? It's still bleeding. It comes right back in. You're not solving anything. The thing for us is we detect it. We find it. It's a finding. And we take them to the nearest appropriate facility to relieve it by surgery. We don't. The pericarditis is interesting in the sense that it's a non-trauma instance, and yet we have this finding. And again, they have to go somewhere with surgical intervention, not necessarily the local hospital, because that's an important thing. Well, why do you have the JVD? Where? What, okay, let's talk about shock. What kind of shock is this? What classification of shock is this? Yeah, but what general classification of shock is it? It is obstructive. And so it's the same classification of what a tension pneumothorax does as well.
Squeezing the heart.
Correct. And what's a tension doing? Squeezing the heart. What's cardiac tamponade doing? Squeezing the heart. Doesn't allow it to do its thing. So in that sense, people for years always thought, I was told when I went through school, well, it's a respiratory problem in your tension pneumothorax, Well, think about it. How many people do you know have had lung surgery and have a lung removed? Did they just fall over dead with one lung? No, they're fine. So it's not a lung issue, it's an obstructive issue. It's a tourniquet effect on the heart and major vessels. The difference between these two conditions, the cardiac tamponade and the tension pneumo, is the tension pneumo gets everything in that upper area. The cardiac tamponade just hits the heart. So when you put a tourniquet on those vessels, what stands up? KPD. So back to our original question as we digressed for a good 5 minutes. Varying blood pressure, arm to arm. What would be another cause of it? What's a common cause of it? Had one yesterday. Females can do it, yes.
I never understood that.
But
I never understood why I'm second.
I never have either. I never understood why they don't want you to start an IV and all that. Venous flow is venous flow. I don't know. Again, I'm not a doctor. Don't even play one on TV anymore.
And it because usually if it's that bad, they take out the lymph nodes and everything out. So
You got to go somewhere where that vein will just rot and fall out. I don't know. There's certain things in life I don't quite get, but who will I know? Early complex that breaks the regularity of underlying rhythm is characterized by narrow QRS, upright P waves that differs in shape and size from P waves of other complexes described below. So again, if you don't know the terminology, you don't know what it is, you might not get it. Okay. I don't know either. Let's figure it out. So, what about the P waves? What's special about the P waves? Go back to cardiac 101.
Followed by different shape, different in shape.
Okay.
And size.
All right. So, what does that sort of describe? Narrow complex, upright P waves, differ in shape and size from the other P waves of the other complexes. Most natural structures, non-atrial escapes, non-wandering atrial. What would be the problem with the junctional? And the uprightness if there are. All right. I didn't like that one. Keep going.
Yeah.
2 minutes of CPR. All right. So if there's a change in CPR, which there was, in our 2015 guidelines or whatever now that come out in 2016, is that on registry? Yes, it is. So follow it. On 2 minutes of CPR, you reassess an unresponsive man's pulse and cardiac rhythm. He remains pulseless, displays coarse ventricular fibrillation. And here's where you have to, and shock is correct, but
Resume CPR.
you don't know based upon the answer, so you can resume CPR as the defibrillator is charging. You can shock if the defibrillator can do what? What? Well, no, we're not talking about AED. We're just it's paramedic stuff, guys. So what we're talking about with our machine in CPR and defib. So you were right. Continue CPR as the defibrillator charges.
If your defib can detect it while you're doing CPR.
That doesn't have to. If the defibrillator can provide this function and do it in less than 10 seconds, which is the magic number for all your pauses and interruptions. Or if it's charged and ready when you say stop and switch compressors. Now let's see what it says. Continue CPR, intubate. Nope. Resume CPR as the defibrillator is charging. I think we said that. Perform 2 minutes of CPR and then reassess. Some people that still think we do that. Lord knows why, it's never in there. Continue CPR and establish IV. So what do we go with? And that was a very, very, very simple question, but it's a process question. So again, for those people that say, you know, you have areas of this state that says, oh, we don't follow AHA stuff. My answer to all those people on there, I know this is being recorded and all that, is see you in court one day. Whether you like it or not, you know, you defib my mother at 500 joules or something you're doing, and she doesn't survive, it's all going to go back to court with, what does the National Standard Curriculum recognize? What does American Heart Association say? It's a crazy world out there, but that's the nice thing about Registry, is that it all follows all that. So stick with it. Performing CPR on an 80-year-old woman whose cardiac arrest was witnessed by her husband. Several intubation attempts have been unsuccessful. Ventilation of the bag valve mask are producing adequate chest rise. So what about the airway? So let's stop. What about the airway? Good. Move on. IV access has been obtained. 1 milligram of epinephrine. Cardiac monitor displays a narrow QRS complex at a rate of 70. So is it organized rhythm? Has a rate. According to the patient's husband, she's been numerous episodes of diarrhea over the past month. This is not much of an appetite. Most appropriate next action would be. There's a couple of problems here. Let's see if you find it. Say it loud.
Check the pulse.
Who cares about her history at this point in time? They're throwing that at you, so you jump right in and do something. Every time you have an organized rhythm, what should you do? That's not after 3 minutes. That's what kills that one. 1 milligram of atropine, because we still don't know. There's not really a wonderful answer to it other than continue CPR and administer fluid. It handles both of them. But the most appropriate next action would be for you and I to check the pulse. The most appropriate next action intervention sequence would be to go ahead and continue. You'll see it says yeah, I don't like that one. Oh, well. Which of the following prescribed medications would a patient with chronic atrial fib most likely take? Everybody jumped on that one pretty good. And I'm not a patient medication fanatic or anything like that. But why did you? Controls the it's a rate. It's for the fib. And what's the feminine for? Yeah, people in atrial fib. That's usually our biggest concern is about production of clots and throwing them out there along with that. By the way, do you know what the most common dysrhythmia is associated with stroke? The AFib, especially new onset, is highly common associated with it. Okay. Patient with heart failure and pulmonary edema. We've already talked about this. What do we want to do? Or what does it do? I guess that's the question. just think, why do you hear those sounds that we just talked about? Why do you hear them? Okay, how's it get there? This left heart failure, pulmonary edema. All right, so by definition, we're talking about this. Are you even really considering A because it's talking about right? Okay, so blah, 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 still in there. B, we think about it. No. Did we talk about this person having an MI as well and all that? Why are we even talking about that? So yeah, C is the correct answer with that. All right, let's do one more and then it'll be 11:35. I promised Glenn that we would beat the crowd for lunch and everything. So of course it's a long one. Got a call to a nursing facility, elderly man with generalized weakness. The patient's nurse tells you that as an ED thing for the past 18 hours, she presents with this chart which states that his history of AFib, CHF, hypertension. Lovely. Why don't we just throw in cold and flu season and, you know, chest pain at the same time? Medications include vasotaxine and warfarin. You apply cardiac monitor. Your partner takes vital signs for meals. Blood pressure. How's blood pressure? Rapid irregular pulse. Okay. How's respirations? Yeah, they're not bad. EKG, atrial fib, variable rate between 110 and 130. 12 lead reveals the same. After giving some O2, what do you think? All right, so he's not eating anything the past 18 hours. I don't really get into the detail. He had anything to drink. He's dehydrated or anything like that, or they give you any information about that. But it also tells you, you know, that he's not processing stuff very well either. He's taking his medications. Are they working? Okay. So if we wanted that rate to slow down a little bit, how do you think we could do that? Again, what would that prudent paramedic do that would safely treat this patient? They need to be cardioverted. Why? Why? And you can have a known condition and it be a problem. What's the differential? Blood pressure. Blood pressure is great. Move on. So, no fluid because the pressure is great. Heart is in, transport. That's reasonable among lots of these things. All right. It's 11:36. I'm going to pause it. Probably take that off. I think we've done enough practice questions. We'll go on to study some stuff. I don't know what the lunch break is. Is it an hour or is it a little over an hour? It is from 1.5. So we'll be back here at 11:35. Be back at nice try. Be back at a little after 1. So give you some travel time to sit down.
Oh, yeah, I guess so. Yeah.
Chocolate Thunder. Maria. Mal.
Come shut your iPad off, Lynn.
actually, really, when you look here, he had a big knot here. And he thought, yeah, it's really strong. He's still healing. He is. Oh, yeah.
I think we're ready. Everybody's here that was here before lunch, right?
That's 13:05, so that was.
Oh,
kickoff
Chad's
time.
not here yet. But, yeah, he's either late or not coming
Why
back.
you got it turned up the different direction?
Huh?
I don't care.
You know what? This is the phone I will trust to throw across the room. All right.
Last time I threw mine, it really wasn't the phone's fault.
The door's shut. Let's see if that's Chad.
I just don't know.
Yeah, when I tell you to introduce yourself, that's the kind of shit I want you to tell them.
All that good stuff.
Yeah, because I
They
mean,
don't believe it.
you're right. I mean,
Well, we're talking trauma tomorrow, so you can stand up.
Let me tell you about the trauma shot.
Huh?
I was reading the news.
Okay. Well, you were fine over there where you were. Michael's gonna lecture for about another 2 hours and 20 minutes or so, and then we'll break up and do station practice for those of you taking the test.
Give everybody.
For those majority of you that are not taking the test, you are free to go. I ask you to be a patient on test day for the paramedic, for the out of hospital scenario. I asked you already. I asked you, and I think I've already asked the other two, but they're not part of class. So in the out of hospital scenario that Matt talked extensively about last week, you will have a true paramedic partner who will basically just be there to follow your orders, but will also, you know, when Matt talked about the crew resource check, you know, when you say to your partner, I'm going to administer 1,000 bags of LR, as the guy did on the video example, the true partner is there to question that order. Okay, so you know, if you tell Pam you're going to administer a drug and you give her a grossly inaccurate dosage, she's just going to repeat your order. She's not going to question your order, but just hopefully by you hearing her say exactly what you said incorrectly, that's supposed to trigger you to say, oh no, that is not what I meant. I'm going to do, you know, the right drug, the right dosage, the right route, et cetera, et cetera. So Brittany and Pam will be two of the partners. You may not get either one of them. Bud Fowler's going to be one of the other ones, and I don't remember who the fourth one's going to be right now. But so you'll have true paramedics as your partners in that out of hospital scenario station. The other thing I want to talk about before Michael starts is we're going to do ACLS EP on Friday, March 3rd as an optional part of this class. If you don't need an ACLS card or you don't want an EP card, Michael will be, have I asked you to do this already? Are you free March 3rd?
I think so.
Okay. Michael will be one of the 2 or 3 EP instructors that we'll use. If you've not heard of ACLS EP, it is the Cadillac course of ACLS. Chad's taken it, haven't you? Dawn has taken it. Mike's been an instructor many times. It is far and away the best ACLS course that AHA's had in 30 years. If you're sick and damn tired of sitting through a refresher class where you don't learn anything, you need to bring your butt to EP class.
For those of you that have decision-making capabilities where you work, we started doing ACLS, and then 2 years later we do EP, and then 2 years later we do ACLS. And by that time, there's an update
New guidelines.
of your of the guidelines with the ACLS changes. And the nice thing about EP is you can actually let us know if it's for a department specific, what some weaknesses are. Like if you run 20 overdoses of heroin in the last, 3 months. You can actually spend lecture time specifically on that. So it is tailored towards
Any
the audience.
overdose.
Yeah, and then you can, when you have the class again, it's totally different. I think we said it was like 62 scenarios or something like
Yeah,
that.
there's 62 out of hospital scenarios, plus there's 50 in hospital scenarios, and there's 50 ER scenarios.
We'll get one of those because it's designed to take you out of your comfort zone as well.
So EP will cost you another $50, and we really, really think you should have the EP book. It is not required that you have the EP book. You can have a regular ACLS book.
Glenn and I have said for years, if you buy one book in the last 10 years, EMS related, an EP book
EP book is what it should be.
It's about that thick.
Yes, it's as thick as an ACLS book was back in the day. Instead of this little pamphlet thing they give us now. But anyway, that
That makes no sense.
right.
The book, that ACLS book makes no sense.
It's not. It's absolutely not geared towards pre-hospital medicine. It is geared for an cardiac ICU nurse. Is who that class is geared for. And EP is more user friendly for EMS. It's still very hospital component, but it has a good out of hospital component also. So I'll send an email out to everybody this coming week, or maybe even tomorrow during class, who wants to do EP, so that I'll have enough instructors. If it's just you guys, then Michael and Brandy that's teaching the basics would be enough instructors with me. And then, but if we have the full class component where there's not a damn empty chair, then we're going to need 4 more, the 3 of us plus 1 or 2 other instructors. But anyway, it is
an ACLS card.
And it is an AHA card, and EP trumps your regular ACLS card.
Is that printed in AHA website somewhere?
It's printed on the American Heart Association Program Administration Manual. So
Doesn't matter now, but it's like, I have some people I like to give that paper to.
For info.
Is that
Yeah.
all day?
And
it
then
will be
we'll-
all day. We'll start at 9, and we'll start at 9 and hopefully finish at 5, so that we have a little dinner time before evening class starts in March. Okay, so we'll start at 9, and I think we can be through by 5.
Yeah.
Maybe 4:30.
Start at 8, 9,
No, start at 9.
9. Okay.
So
It's a good class. It's one of the few that we wholeheartedly believe in anymore.
yeah.
And that's the third.
Yep. They're all yours.
All right, so we're shift gears a little bit more, get away from the question and answering with it. So you will have skills in a little while, or practice, and even if you are not, if you're just here for hours or whatever, come help hang out for at least one or two or something. Everybody in here offers something in here. Last class I was in, a good friend of mine, he said the same thing. He said, there's no class I've ever been to that I didn't learn something from somebody in there. And all that's important about for daily living, your job. It's also extremely important for things like this, for those of you that are testing. If you learn anything about something that's an advantage to help somebody else, please share it. We do live in a world of secret squirrel and all that, and people want to hide their stuff, but I think all of us together really know the answers to it all, but not one person does. All right, so the subjects, these are the things that you need to know and review and just feel comfortable with. And when you look at the bullet points on here, and if you say, yeah, I've got that, I know that, whatever, holy cow, blood flow through the heart was the one that killed me the first time I took registry 20-something years ago. And son of a gun, if every question depended on blood flow, it was a paper test and like 5 questions in a row on blood flow through the heart. It was one thing I didn't care about or study or whatever. I still have no knowledge of it whatsoever. I know it goes in and it comes out and it pumps. They're wonderful. Strip recognition and treatments. Again, we cardiology is in a little section, but with your strips, if you don't know the rhythm, then how are you going to treat it? And then back to what I said before, know the signs and symptoms and the stability of the patient. Your treatments on National Registry are all based upon the stability of that, and your ability to read that question and understand, is this patient doing okay or are they not? And they may not give you a blood pressure each time. The golden rule is if the blood pressure stinks, what was it I learned from one of the guys, it was here in Cleveland, it was probably 2 or 3 years ago. He had a quote that I loved. He said, if it's unstable, grab the cable. And that's true. And if you don't get a blood pressure and all they say is they're pale and they're not making sense when they talk, well, guess what? They don't have perfusion to the brain, therefore they don't have adequate perfusion. So just keep it very simple. But if you don't understand that in ACLS, it will cause you problems. So MI, CHF, the pulmonary edema, the little thing I told you about, and the fluid and the crackles and all that, they could try and throw you off by not specific, or they could throw in wheezing. And you have wheezing with pulmonary edema. I just showed you why. So yeah, angina, hypertension, cardiac arrest, tamponade, pericarditis, endocarditis, cardiac failure, cardiogenic shock, which is a big one now with ACLS, the post cardiac arrest care. It's the ACA algorithm itself, and it's part of every scenario that you have. There's a little bit of it. So I would know that very well. What was the medication that sort of made a bit of a comeback with that is used to increase the blood pressure if fluids don't work? Norepinephrine, also known as? Yep.
Lemonade.
Leave them dead with Levophed. That's correct. And it works very well for that. Does anybody know what, you said what's the other name for Levophed is? No.
Oh, I was like, what?
Yeah. Norepinephrine. Does anybody know what dopamine does? I know you know it's a potent vasoconstrictor and it increases blood pressure and all that. Anybody know what's very special about dopamine, what it does to the body that helps improve blood pressure? And that's all true, but how does it accomplish it? And this is why norepinephrine has always been kicked around. Why is this not the primary drug to improve blood pressure? Dopamine triggers or stimulates the release of norepinephrine. So why would you give a drug that makes the body to release it when you can just give norepinephrine? So in theory, it should cut your patient response time in half. Not a drastic change. In other words, you're not making the patient, borderline hypertensive in a matter of seconds. What you're doing is you're cutting out the middleman, hoping that you'll see the response in the patient sooner. AAA, DVTs. I'm going to skip through this because this is not my sections that I have. This is just part of the presentation that I have. But it does have endocrine, medical emergencies. Is it medical differential diagnosis? DKA, we had a question on that earlier. Does anybody know Walter Payton? Everybody heard the name? What's he famous for? Football, Heisman Trophy winners. Everybody know who Walter Payton Sr. is? He died in the county jail, pulled over for DWI, DKA. And so, differential diagnosis of what's going on. Hyperglycemia, hypoglycemia. Always forget this. I have to look it up. The internal adrenal, the HHNS problems. I always forget what it stands for. Pituitary and thyroid disorders. I told you will see those. You will. It's nice to be familiar and browse up on those. Adrenal disease, Addison's, things like that. Cardiorespiratory system. We talked a little bit about pneumonia, presentation, emphysema, bronchitis, asthma, COPD, respiratory arrest, wheezing, stridor, rails, and croup. Epiglottitis, pertussis, RSV, cystic fibrosis, foreign body airway obstruction, pulmonary embolism. What is the presentations are very similar with croup and epiglottitis. What's the differential diagnosis on those two? Seal-barred cough is present with who? And what's the other one have? May, both of them can have stridor. But drooling. Leave it to registry, though, to leave out the drooling on epiglottitis, which is the primary dead giveaway of epiglottitis. How would they make it present then? Painful, refusing to swallow, that type scenario, or you find them sitting up and leaning forward. So interesting of those two. Yes, know the difference between the two. Your CNS issues, the stroke, the different forms, differential TIA seizures, even though it's maybe resolving, you should still treat every TIA like in that test question. You don't know for a fact because you don't have the CT and you're not a doctor, so treat them the same. Seizures, we talked briefly about that, and I do want to throw something in there. So somebody has a seizure, never had a history of seizures, there's no fever, there's no trauma within the last 24 hours. What are some other possible causes? And on the question that it gave you, it was a very good one. It was from a, brain tumor. The always famous quote from Sir Arthur Conan Doyle, who wrote Sherlock Holmes, he always said that you always rule out everything that's possible and probable with this particular situation. And whatever's left, no matter how improbable it is often the answer. So we never think about brain tumors, as the cause of our problems with patient cares, but it needs to be a consideration. So you have new onset of seizures. There's no fever, and this is actually a case that I had one time. Guy's playing golf, has seizure. Never had a seizure before. Don't want to go to the hospital. He's fine. All right. What caused a seizure? Let's think. What are the possible causes of it? You throw it out and I'll answer.
No trauma. Was it trauma?
No.
Temperature?
Nope.
Alcohol?
Nope. So what mnemonic are you citing?
I'm not involved in my head.
All right, there is one though, and you're going down the list of it pretty good. AEIOU tips. Remember that one? Alcohol, insulin, epilepsy. We'll see it here in just a second. What I like ACLS-EP is they go back and the stuff you learned 20 years ago that was really important that people have forgotten. It's actually in the manual and they talk about it. And the tips, of course, is trauma, et cetera, et cetera. So,
Ingestion, poison.
yeah, none of that. So it is one of those. I'm gonna give you a hint. It is one of those, but it's not. Doesn't jump out at you. Talk to the wife. Nothing. And you get down to the point he's refusing, and you say, and I'll show you this in the video in a little bit, and this is from AMLS, but anybody know what sample history is? Do you might know what sampler history is? What's the R? No. A lot of texts now are adding the R, and it's for risk factors. And so what does this person playing golf have as a risk factor? And talk to his wife. And so she said, well, you know what? And all stories always end the same after the fact. They always say, there was always this one thing. There was always something. Just like when they have the serial killer in the neighborhood, it's always, oh, he was such a nice guy, But there was just that one thing about him, that everybody could put the finger on. So he's just been a jerk for the last 3 months, and he's not like that. And there's no reason why. There's no stress at work. There's nothing unusual. Well, anything happened several months ago? Well, he was in a car accident. Well, you say, well, we asked about trauma. No, we asked about recent trauma.
Not past.
So what happened in the car accident? Well, he didn't wear a seatbelt. He hit his head on the steering wheel, went to the hospital. They said everything was fine. He went home. A couple of weeks later, he just had his personality change. He had a bleed in his frontal lobe that was just a slow self-resolving, everyday trickle until finally one day it cut loose. And that was a seizure, and that was the reason for his personality change. He had pressure where it shouldn't have been. And he coped with it. He compensated for a very long time. So you just never know. So that, or I like it because you always have to ask the question, you know, has something like this happened before? Is there something here that just is very unusual? And it's kind of a good way to go. So we talked about that seizure, the types, everything. The other last interesting seizure I had, and somebody here recently described one to me, and I said, well, have you, how were they cardiac wise? I went to a seizure call, and the guy's sitting up talking, yeah, I had a seizure, and the wife was like, well, yeah, he just shook for a little bit, and then he was right back normal. And I was like, yeah, right. You want to go to the hospital? No, not really. Okay, sign here. While he's signing, he has another seizure. And then I'm back, and I'm like, okay, you don't want to go to the hospital. What's your game? If you're faking, what do you have to gain by this? And so I was like, are you feeling all right? And he goes, yeah, I don't know what happened. He says, you were talking to me and I don't remember it. Well, I'm getting the information, put him on a heart monitor. Beautiful sinus rhythm. That's great. Talking to him. He goes flatline, has a seizure, and then back. He ended up getting a pacemaker. So what happens to the brain when the heart's not pumping blood to it? So he had a hypoxic seizure. Do you know that one of the largest portions of the 911 calls for cardiac arrest get called in as a seizure? Absolutely. So something to think about. Headache, dementia, demyelinating disorders, Parkinson's, cranial nerve disorders, hydrocephalus, neurologic, traumatic brain injury. We'll do trauma. I'm sorry. I'm going to see this. I got ahead of myself. In your OBGYN and Peds, which is also part of the medical, like I told you before, the eclampsia and preeclampsia, the differential between the two. They're exactly the same, but there's one that sets it forward to something else. Seizures are now present in the eclampsia. Abruptio and placenta previa, differential.
1% stays, 1%
Absolutely, but you don't see that. Differential diagnosis, pain. Absolutely. Which one has it? Yeah, abruptio has severe pain with it. Placenta previa, had one time. She was just, I don't feel good. I keep bleeding. It's about the color of that ball. Massive bleeding. Breech. Or ectopic pregnancy, breech birth. What's the most common breech? Nope. Buttocks. What's also known as? Nope.
Frank something?
Just Franks.
Oh, just Frank.
It's known as the Franks. I'm throwing this out here because for those of you that are testing, just digging back in the old memory. And for those of you are, you might see that as a term. You didn't know that.
Middle section, they got away from some of it. I guess they redone some of the tests and they're really back.
Terminology is just, can you see it with me? Terminology is a big deal with it. One of the questions that I kicked myself and missed, and again, they painted this beautiful picture, 47-year-old female complains of gnawing and burning of her gut. Melina is present and she's pale. What's her problem? Huh? No. Blood. Where? In the stool. And the answers are something like ectopic pregnancy, upper GI bleed, lower GI bleed, appendicitis. And if you don't know what Melina is, you don't get the question. Because it's very similar. The signs and symptoms presentation are very similar to all those things. Now, if it was, blood in the emesis, then it would be upper GI bleed. If they just said black tarry stools, like you expect the answer to be, and it's not the answer that you will see, it's Melina. If you're not familiar with the term, you just did. You just get very familiar with it. miscarriage, childbirth, breech birth, prolapse forward, supine hypertensive syndrome, para, and gravid. So why don't we always put in supine hypertension syndrome, I always put females on the left side, why not the right?
So they get them, put them in here, then they'll pass out in about 25 minutes.
Okay, if you put them on the right, it should get it off of that as well, right? If you got, I was trying to look for it in here, if you have the good old anatomy pictures or the skeleton that has the major vessels, what's on the right side? Exactly. And so right side's okay if there's like trauma or something to the left. Left side's preferred though because of that reason. Both will work. Left side works the best. You just take
I
into
didn't hear what she said.
what?
I didn't hear what she said.
About,
Right side.
yeah. Oh, okay. I
You're
got
actually looking at the little anatomy picture.
Yeah.
She said, yeah.
And so knowing simple things like that gets you a really, really long way. What's para?
How many times do they mean pregnant? No, how many times do they live births?
How many babies you got? And grab it. Always remember it is the term, if they have a gravid uterus, that means there's a baby inside. So how many times have you had a baby inside? Doesn't mean how many live births, doesn't mean anything beyond that, but that's just a separation of the two. And that's just in the form of a simple question. You either know it or you don't. Pharmacology as well. Altered mental status, all the AMS stuff with it. Drug abuse, dehydration. Dehydration, treated a little different in our age populations, in your peds population. Normal saline is a phenomenal drug. In the adult population, normal saline is just something you hang and occasionally give a bolus of. So in your SVT for your pediatrics, if you have a good history of physical and you know it's dehydration, you don't treat the pediatric SVT with adenosine or cardioversion unless they're drastically unstable. You would try something like fluid. In adults, your SVT is usually treated by either your vagal maneuvers, adenosine, or in worst cases with cardioversion. So just remember the different age groups, remember the different things you do. Hyperthermia, excessive heat, hypothermia. Let's talk about hypothermia a little bit because there'll be a little section on that. At what temperature does the body need to be to metabolize drugs if you're treating a hypothermic patient, cardiac arrest? There's might some people in here now that might be at 97 degrees. Okay. One of the things you have to remember is this temperature does not necessarily mean mentation, alert, that kind of stuff. This temperature just means that functions are going to process in the body. It's lower than you think. Magic number is 86. So if they get them above 86, the drugs will metabolize. If it's below 86, you're to defibrillate one time and warm them, and they're not dead until what? Until they're warm and dead. So hypothermia treatment, as far as resuscitation, if it's cardiac arrest, is work them. You may defibrillate at one time. A cold heart does not respond well to defibrillation. It does not respond at all to medications, mainly because the liver stops it, and you get that patient above 86, then all the drugs get dumped into the body all at one time that you shoved in there. So not something that you really want to do. So get them warm. That's the problem. Drowning. A lot of discussion and controversy in the last go around with the AHA updates, and they kind of stood firm, but you kind of have to dig for it. Is there anything different you do for a drowning code than you do for the guy in Walmart that's 99 years old, 400 pounds, and has his oxygen, a cigarette, and a cup of grease walking around with it? Okay, so yeah, all right, so that's just correct, but we're going to knock that off the list because we just talked about hypothermia, so that's true. Is there? We don't know. There could be, there could not be. Wet versus dry, salt water versus fresh water. Gosh, there's a lot to talk about with this. Answer to you do work it a little different. drowning, and this is another ACLS EP type thing, drowning and lightning strike work a little bit different in the sense that you're dealing with a respiratory component first. So all your CAB is wonderful. This is probably not one of those cases that you worry about compressions, airway, breathing. Probably need to worry about airway and breathing first. If there's water in there, how do you get it out? You don't. The body will take it in or it will squeeze it out all on its own. You have to ventilate. Mouth to mouth, pocket mask, bag valve mask, or even intratracheal intubation will move that stuff around and get it out. On a cold, damp day, when you see your breath in front of your face, what are you seeing? And you don't drown by the end of that day, so it's all right to have some water in your lungs. Here's a golden question. So drugs down the ET tube. Let's talk about that. How much fluid can you put down the ET tube? Max. Close. It's actually a perfect number. Good way to remember something. AHA stance and respiratory says, well, you probably should never put anything down the ET tube. But can you push drugs down the ET tube still? Absolutely. There's no reason to with the advent of the adult IO, right? But if you have to, there's certain ones you can push. What are they? Just remember lane.
Yeah.
Lane or lean, that's correct.
Lean V.
No V.
Is it
Hmm?
The V's gone?
The V is gone. It used to be Valium, then it got gone. Then it came back as, you can talk, it's okay, say it out loud. Vasopressin. In the last AHA update, vasopressin was removed. Why was vasopressin never used down the tracheal tube? Okay, it's an expensive drug. What's the dosage of it? 40 units. How many times were you allowed to use it? So how many doses did you have in your EMS card? So how do you double the dose down the ET tube? There you go. Sometimes the answer is not in the textbook. So vasopressin was never proven to be more effective than epi. And since you had to stop and wait 8 to 10 minutes before you could give more epi, vasopressin just got removed. It was shown to be effective. So V got gone, even though it came back. Now it's gone again. Well, maybe we'll find another drug that starts with a V. We can use it. But lean or lane, it works. Lidocaine, atropine, Narcan, epinephrine. Why would you give Narcan down the ET tube? I have no idea. You can give it IM, sub-Q, intranasal. There are now studies saying that intranasal Narcan is faster than IM Narcan, just because it's so readily absorbed into it. I think you put it in hand lotion, it'll probably work.
I was seeing, I was reading something the other day that lidocaine,
Lidocaine's gonna what?
lidocaine's gonna go bye.
It made a comeback this go around with ACLS because the original studies published 10 years ago when they had the big change in ACLS, or probably 11 or 12 by now, is that more people got a pulse back with amiodarone than they did with lidocaine. And that's true, that's factual study. What they did not share was more people walked out of the unit and went home with lidocaine than did amiodarone. So what they're saying now is pick one, have at it. That's their stance by it. They're saying lidocaine is useful for very specific types of your ventricular ectopy and work very well. Amiodarone has another little area of expertise, but both overlap and will work fine for either one. It's your choice.
But the reason I'm asking that is, studied cardiology last time we were here, and she's not here this weekend, but the girl from Nashville said, don't even tell me anything about lidocaine. If I hear lidocaine, I'm going to have to go to the National Registry person and get their opinion.
Okay. I'll tell you what their opinion is. Follow ACLS. Pure and simple. There's like I said at the beginning, there's no debate to it. It is what it is. So you can use either. It just has to be correct with it. And we can pull up the algorithms that break or something if you like to. So back to our drowning, we said we need an emphasis, and AHA basically has always said the same thing. Just like with innovation, they never said don't ever innovate somebody. what they said is, if you can do it and keep your interruptions in CPR of less than 10 seconds, and you're very proficient at it, we are not talking to you. But if you are trying to get your third tube for the year and you're having a hard time, you should use a blind insertion airway and stop interrupting compressions to do so. So you find the airway that works and uses it. When do we intubate in ACLS? There's two times that you kind of have to.
After. No.
Well, there's 2 times. What if you pick one? You say one. You say one. No.
As you get Ross back before you go.
Ross, correct. Ross, if they don't sit up, start talking sense. And how do you determine whether they get? And remember, they took out target temperature management for EMS providers, but for in-hospital providers, they still use it. And that's therapeutic hypothermia is what it used to be called. So how do you judge whether this person gets therapeutic hypothermia? Let's say they are intubated. They can't talk to you. What's the thing that sets aside? Either they get cold fluid or they don't get cold fluid. One thing that happens. Ability to follow verbal commands. Can't say answer questions completely because they could be intubated or they could have a king airway in or something. So, and don't ever, just as a personal thing, don't ever do the, hold your hands up for me. Okay, you didn't see this, but take a look at her fingers. Okay. Human beings have a natural tendency when you do that, to do that. So if you do that, incorporate it in the sense of, Mrs. Jones, squeeze my hand with your left hand. Let go. Squeeze my hand with your right hand. And it's that following of the verbal commands where they don't just do the squeeze my fingers. You slide your hands, and most people's hands, they close. We all know this. We've all had that altered mental status person on drugs or whatever, and they tape the thumbs to the rails and they latch onto the rails, and we do that. No, don't do that. Anyway, so the ability to follow verbal commands tells you that intubated or not, or even if they're not responsive, if they can follow verbal commands somehow, then they're mentally and neurologically intact. Therefore, they don't need the preservation of the therapeutic hypothermia, or now called target temperature management. So, back to our drowning / hypothermic patient. We take that person and we're very concerned about their airway, same way with a lightning strike. That, in the use of lightning strikes, we use what's called reverse triage, because most lightning strikes on a golf course and there's 5 dead people, you say, oh, well, triage, they're dead. We move on to the people wandering around. People wandering around are getting better by the second. People in cardiac arrest can actually be saved. Again, they're not 400 pounds, 90 years old, have a cup of lard and cigarette in their hand. They didn't go into cardiac arrest because of a cardiac issue. They went into it because of an electrical issue that either put their heart out of sync or paralyzed their respiratory muscles. And so, again, another simple thing that's easy to fix. So by just doing ABCs on your drowning victim, you may be able to get the airway open and moving, and get the water either displaced or whatever. The magic number for the drugs down the ET tube was 20 cc's. And why that's magic is you can take 2 amps of epi, 10 cc's each, twice the dosage of IV. You now have your first drug down the tube. It is the only drug down the tube because after 20 cc's, what happens? Wash away the surfactant so the alveolar sacs don't do what it's supposed to do. And the other thing is, instead of oxygen, there's now a fluid there. We are not fish, so we have to have air and not fluid. So 20 cc's is a really good number to remember. How much can you put in the deltoid if you're giving an IM injection? 5 cc's. Good. I don't see that before.
That was a test question.
Okay. 5 cc's is the number for the deltoid. I'd make sure I knew where the deltoid was. You're talking about somewhere else, it could be more. Okay.
The question today, the, subcutaneous, isn't it two?
Sub-Q, I said IM.
That- yeah. Is it two?
I don't know, that sounds good.
Yeah. Can't remember.
I would have gone with one just because most of your sub-Q syringes only are a 1 cc syringe. But sub-Q might hold,
That was small.
yeah,
I know, 'cause
it
that's
should be,
the
it should be
TB
pretty
test,
small.
right?
TB test is 0.1, I think. It's minuscule,
Small.
it's very small. And you think things like this aren't that big of an issue, they're not important. They are when that test question's right in front of you and you don't know the answer. And you never talked about it. You know, don't make notes on this stuff, you know, because if you see it, you'll remember it because we had the discussion. Decompression sickness, sickle cell, meningitis, overdose. Overdose and their antidotes. Very, very common and popular on there. All right, so let's talk about them real quick, and that'll save us some question and answer and all that kind of stuff with it. So we know that narcotics, what is the reverse agent for narcotics? What does Narcan stand for? No, that's the other name for it. Narcotic antagonist, Narcan. How did it get its name? Narcan. Okay. So think about that. So our narcotics, our opiates is Narcan. What's our benzos? Yeah, flumazenil, romazicon, also known as romazakil. Why they call it romazakil? Seizures. You know, I had 2 paramedics one time told me when I told them I didn't want that on the truck. I was training officer. They said, well, if they go into seizures, we'll just give them Valium. Okay, Einstein, you just gave them something that counter affects the use of benzos. What's the most effective treatment, the preferred treatment for your benzos overdose? I'll give you a hint. It's the same reverse agent for succinylcholine. What's the reverse agent for succinylcholine? And there's not a magic drug for sucks. And you can give flumazenil in some bad cases for it, but it's very dangerous. It has a high risk of seizure. What's your only problem with your benzo patient? Hypoventilations or respiratory arrest. That's it. You know, it does affect the blood pressure some, but if you're not moving air, you're probably not moving a lot of stuff with the blood either. So take over the ventilations and let time do its thing. And so, but the official reverse agent for benzos is romazicon or flumazenil. How about our calcium channel blockers? This is an easy one. If your body doesn't have enough calcium going into the cells, higher concentration to a lower concentration, add more calcium to it. Correct. Calcium also works well with what type of envenomation that has problems. Not just envenomation, but envenomation and then signs and symptoms. Well, let's talk about that because that has to do with our environmental, our medical. What's brown recluse do? It's a hole in your skin, so you're not worried about problems other than that. Black widow, it's a neurotoxin. It forces calcium outside of the cells, causing your respiratory muscles to go into tetany. If you don't have enough calcium, how do you fix it? Put more calcium in. And that only works for those patients that are experiencing abdominal pain, cramping, and muscle tremors. Just because you get bit by one doesn't mean you're going to have problems. I got bit by one once, and after about 10 minutes of pain and writhing around, the spider finally died. And it was actually true. Put on a pair of yard shoes, felt something, took it out, and it was black widow. I was like, oh crap! So I sat there, it groped, and I got up and cut the grass. So, but it does greatly affect the elderly and pediatrics just because of their response and their nervous system. Pediatrics being immature nervous system, elderly people not being able to respond well to the nervous system. Why is the abdominal pain such an important factor with black widow? What's it really close to? What's this thing right here?
The heart.
Diaphragm.
Oh, no.
So it knocks out the respiratory drive. That's the goal of the black widow, is to get its prey to stop breathing so it can eat in peace, not get kicked smacked around. I assure you, there's probably not a black widow big enough to take on me, so it's not likely to kill a nice, relatively healthy adult. Can cause some problems though. So that's another case of the calcium. So let's go back to our overdoses. What do we do for our tricyclic antidepressant overdose?
Sodium bicarb.
Sodium bicarb, how much?
A lot. It's like, I don't
Yes
know.
and no, yes and no. It brings up an interesting point. What is the average adult dosage in ACLS of sodium bicarbonate? Negative. It is an easy calculation. It's the same as lidocaine, roughly, because it's not in milligrams, it's in milliequivalents, MEQs. 1 milli equivalent per kilo. So, how much is in a box? Oh, come on, you guys should know what's in a box of bicarb. No. What? 50 milliequivalents. So an average adult should get roughly, most adults are going to get about 100. They're going to get 2 boxes. They're going to get 100. So how many of you all these years have pushed an amp bicarb on somebody and now you're sitting there thinking, we've underdosed them? I have. I knew it. Or knew the dosage, but still just gave a box because that's what we did. So 1 milliequivalent per kilo, that's your tricyclic antidepressant overdose. How do you know if the TCAs are kicking in? What's true about the patient? What will they have? What about it?
Widens out.
Widens out and it's fast.
What is it? Widens out and fast.
YQRS tachycardia. That's a pure T. I mean, that's one of the reasons that you know, if they took a bottle of tricyclic antidepressants, great. Their signs and symptoms of vital signs are great. They don't need it. They start developing that, they need it. How many of you work somewhere that allows you to do NG tubes?
I can really see that.
Nobody? They let you do it for overdoses or just cardiac arrest here in the stomach? But you can. That's good. I think that's a lost art. And I think the whole thing of, and let's stop everything for a minute because this goes into my opinion, the whole thing of you do it after intubating, I think is a crock, because there's 2 things beneficial to an NG tube. When you go to intubate, number 1, vomit doesn't come up in your face. And number 2, if there was air in there, that got rid of that, so it's easier to ventilate with VVM. And then the other thing is when you go to intubate and you can't see the cords, but you see a tube going into the stomach, you don't follow that tube. You go somewhere else. So I think, you know, and the overdoses I've had, you know, we didn't wait till they quit breathing and were arrested before we did an NG tube. So I think the whole argument's preposterous. I don't know if you started crazy. So what about our poisonings, insecticides that causes excessive secretion? Atropine. Yeah, most of us just have atropine. So what's that classification called? No, what's the poisoning called? Organophosphate poisoning. Another ACLS EP thing. It goes back to sludgem or dumbbells. You remember what that stands for? Salivation, lacrimation, urination, defecation, GI upset, emesis, and meiosis. So basically any orifice that can leak fluid does. And how do you give atropine for that instance? And I know you've all heard the story, you don't have enough on the ambulance, that's true. 0.5 IM in the deltoid instantaneously. Don't screw around messing with an IV. Once you get an IV secured, I want to say it's 0.1 every 3 to 5 minutes, or even some odd place that probably can do a atropine drip. You're not worried about rebound bradycardia. You're not worried about pushing it too slow because you're not giving it for bradycardia. You're giving it to dry up secretions and keep the heart in check. Who has large quantities of atropine? Vets, large animal vets. Don't go to a serpentarium. Okay? Stop at the people that work on horses and cows. They'll have large multi-dose vials. Absolutely. All right, so we got a couple more overdoses to talk about. What about beta blockers? Glucagon, and now they're showing that there is some instance of giving, I don't want to steer you wrong, I want to say it's bicarb also in the presence of a beta blocker. And again, how do you give the glucagon? Just like you do for diabetic. Stick it in the arm or give it IV. I always thought that was funny that glucagon was IV or IM. I have an IV, probably going to treat the hypoglycemia with dextrose. What kind of dextrose, by the way? What's recommended now? Everybody's make a push towards D10. And you can take D50 and take D10 with it, still carry your D50, but there's a lot of legislation and lawsuits out there after D50. So you might want to check with your agency and say, hey, why don't we go ahead and shift over to D10 now and not be having it taken off the truck mandatory by the state within a year or so. Infiltration, nerve damage, muscle damage from the necrosis of D50. I'm going to tell you something. The drug insert says, does it say how to give D50? Slowly through a large bore, free-flowing patent IV. And how many times have you guys had somebody that had a 22 or a 24, it wasn't running really good, you tried to give a little bit and let it run, but it didn't, so what'd you do? You pushed it a little bit more, because we got to get that sugar in, right? Y'all know how, why does D10 wake somebody up faster than D50? Back to osmosis, or as a student I once put in a fill in the blank, I didn't know, they said osmosis. So you have your cells and diffusion. Well, osmosis, how does osmosis work? It goes from a higher concentration to a lower concentration, right? So you put in an isotonic solution like saline, what happens? Goes right into the cell, right? No big deal. What if you inject water? What is water? That's a hypotonic solution. So in order for that to get into the cell, it's a low concentration, so it's readily sucked up by it, and it hurts when you inject water. And cellular-wise, it overhydrates and can rupture cells. That's why we don't use it. That's why we use saline. So then we come to D50, which is a hypertonic solution. When you put a hypertonic solution in, it cannot cross freely into the. So what does that do in order to make it an isotonic solution? Each cell has to give off sufficient amount of water so that in the blood, this D50 now becomes what? D10 or D5 or whatever else. So you're making the body work harder to process it. But when you give D10, where does it go? There's not a lot of process involved when it goes straight in. So if you recall, you need to think about the last time you saw a partner or a physician or a nurse do the whole with the D50. What did the patient do? They laid there very still, and all of a sudden, where am I? All right? Pretty much what they did. Give D10. Hey, my sugar drop again. That's what you get. And so it's a lot easier on the body. And also, if your IV infiltrates, you're not out of anything. if your IV infiltrates D50, there's people that have lost muscle, they've had surgeries. Who gets D50 typically? What type of patient classification? What type of disease process do most of these people have? And they're known for wonderful circulation, correct? And so we want to necrose some tissue with somebody like that? Sure, that's a great idea. So help advocate the push towards some pre-mixed, you know, and what a lot of places do, they just find the little bags of the D10, and they'll just start an IV, piggyback it in, turn it on, walk away, and it does its own thing.
Why is that push happening?
Should have happened a long time ago, and it was all about lawsuits, litigation. Because an attorney somewhere found, oh, hey, this is something in the insert that you shouldn't do. Free flowing IV, large. You're not really going to hurt somebody with D50 that way. But if you're giving it through a free running IV, running wide open through an 18 gauge, and you're giving little bits at a time, you're not giving D50. What's making it to the patient? D10. So in the perfect world, you weren't given D50 anyway by the instructions. So let's move on, because we talk about D50 all day. This is one of the simplest of drugs. EMT intermediate can give it. And it can really be problematic. We used to think it was a wonder drug. And so we just, you know, things aren't always what you see. So we talked about calcium. Who gets that? We talked about calcium channel blockers. We talked about narcotics. We talked about benzos. We talked about organophosphate poisoning. There's always one more. Always forget one. Dextrose, if it's oral glucose medications, they overdose on just any type of sugar solution. Dextrose. I'll think of it in a minute. I always forget it. No, those are the majority of your overdoses that you need to treat. Nausea and vomiting. Which medication gets rid of nausea? Which medication gets rid of vomiting? They both have similar properties, but they also do some very specific things. Zofran's wonderful for nausea. Phenergan is great for vomiting. And the rest, do you know what Phenergan's classified as? Antihistamine. You know what else they give in really bad anaphylaxis patients? They give, you know, the Solumedrol, the Benadryl, the Epi, an H2 blocker, a what? For the, and why do a lot of anaphylactic patients present with either vomiting or diarrhea? Because of that H2 issue and all that unchecked and fluid rushing in. And sometimes you will have an anaphylactic reaction that only presents as, it mimics a vagal response. As you go to the house, the dude's pale, he's sitting on the toilet. Only problem is blood pressure is low, but it's not super tachycardic, or it's tachycardic instead of bradycardic, like somebody had vagal down. Again, differential diagnosis. Okay, so pancreatitis, what those people present like? Where's the pain? And what do they often present as? The answer of it. Yeah, a lot of vomiting. What kind of vomit? Well, like greeny, nasty looking stuff. And some of it. Kidney stone. That's becoming a common EMS call. Here's one of the common causes of soda, sweet tea, you know, water, you name it. What kind of water? Well, any kind of thing like that, yeah. But typically, well water, they say because of the deposits and all that.
Generally, this area is considered part of the kidney stone.
It is absolutely for that reason. Because a lot of it. The nice thing about it is, I have city water, and so I'll never have a kidney stone, but I'll die of chlorine poisoning because they sent some out the other day. Said we're sorry, but we accidentally didn't know what we were doing. So here's your water bill. Thanks for nothing. My sister-in-law has a pool. She took the water to be tested, and they said, "Hey, no, it's good. Do not add any more chlorine to this." She said, That's tap water that's in it. Oh, have a nice day. Yeah. So, pool water is very common where I am, so it's great. So appendicitis, how's that present? Rebound pain, where? Right, lower quadrant. What can also accompany it? Can have some fever and nausea, vomiting. Nausea, vomiting is that one. I don't even know why they even put it in stuff, because it's the answer for everything. Can have that as a sign and symptom with it. What's another sensation that people say when the appendix ruptures? That's afterwards, but when it ruptures, usually it's every patient says the pain finally just went away.
Oh, really?
Well, I mean,
I hadn't actually heard that
it
one,
dumps
okay.
the contents in there, which is terrible. You get
What was it?
peritonitis, but the problem is now gone. Then you have other problems that occur as a result.
Exactly.
So-
Actually, say, I've never heard that.
They will say, you know, they'll all of a sudden they have sharp pain and they'll go, good. And that's really what you don't want in a cardiac patient, because I've had that happen before. Oh my God. And they grab the stretcher and you're like, they're going to cut it like that.
Yeah. Here it goes.
So that's usually what happens, but I've had two patients that both
Michael?
got an aspirin, both of them breathe perfusion. They
Michael?
breathed down and then went into a sinus rhythm. So sometimes that whole ooh is not always a bad thing.
Michael
Bad
Crater.
thing is you go to the hospital. There's, well, yeah, but in like 4% of your students, if you get them at the time and the study's in the right place, they'll aspirin will do it. That streptokinase, still see that much? No, very expensive streptokinase strep. It was what they used for
Michael Crater.
stuff like that. You calling?
Yes.
What's wrong?
Misty has a question.
Go for it.
I didn't have a question. It was actually on one of your slides way before when you were talking about who puts down an NG tube and stuff like that. I was just going to, if they're already intubated, just drop the OG tube. You don't need the NG tube.
Well, that's true too. And I use it often synonymously, but yeah, if they're already intubated, then you're not worried about the gag reflex. Absolutely. And just follow it. And that's used quite a bit to deflate the stomach and things like that as well. Best person in the world in this room doing CPR is going to put air in the stomach when you're using a bag valve mask. It's unavoidable. But yeah, that's an excellent point. And that's why it's called an NG or an OG tube. Thank you. And there is actually a PEDS question, or used to be in PALS, about an OG tube. And what's the difference between the NG and an OG tube to a conscious patient? Gag reflex, absolutely. In the presence of a PED, when you know it is a vagal response, you can give atropine to a PED when you know it's a vagal response. So an OG tube would do that, and people always miss that question because they see OG tube and they think NG tube, or a lot of people do. I did, so I was done. All right, so when it goes into the nose, it's just like an NPA. It doesn't stimulate a gag reflex. It goes in the mouth. It can, if it moves, tickle the, it will elicit the gag reflex. So it's simple. Just a location. We talked about appendicitis, behavioral emergencies. Again, one of the big topic for today is differential diagnosis. Make sure it's not trauma. Make sure it's not medication error. Make sure it's not hypoglycemia. So anything that causes altered mental status that is not a history of this patient, always rule out the other things before calling it or classifying it as a behavioral emergency. Renal failure, the do's and don'ts in as far as the patient treatment. So here's a good case scenario. You have a patient that is brought in by transportation to the emergency room. They have missed their last 2 dialysis appointments. They were on their way to the dialysis appointment when they were just too sick. The driver felt that this person did not going to make it, brought them to the ER. 10 minutes upon arrival, they code. It's one of the first medications you want to give that patient that has not made his last 2 dialysis appointments. Sodium bicarb. How much?
A lot.
What's the dosage?
Whole
1 milliequivalent per kilo, which is roughly going to be 100 milliequivalent.
Give more. I'm like, we can't leave. They're like, no, you're taking them out. We can't do anything with them. Give more. Give more.
What you just said.
And for tricyclics, it's the same way. It's just you give it every so often.
What you just said, I literally had that 3-4 weeks ago at Dallas.
And then away, and it's the vast alkali. Do we have an acid solution we can give for patients like that? No. So here we go. Lung fields assessing. Did you know that there is, they now do sort of verify that there are 6 in the front and 6 in the back? Well, think about it. Does your lung actually disappear because the heart's there? You have 6
Sure, it
fields.
just goes away hot.
So communicable diseases, know the ins and outs of hepatitis, HIV. What's the other big one now that they want to talk about in every bloodborne pathogen class?
Tuberculosis.
Well, they always talk about that when you have, what's the one that's made it into bloodborne pathogen in the last 5 years? That's more recent than that, yes. But what's the other one? MRSA.
Syphilis.
Selling what is it? Penicillin. I hear these whispers behind the screen, and I know it's you. You can speak loud. It's okay. I've been wrong a lot today, so it's okay for you guys to be wrong too. So you're penicillin resistant. I was telling you about, Glenn and I were talking about the ACLSEP, and one of the things that's mentioned in there for your tricyclics, what classification do they call tricyclics? What did they used to say? And it's actually in the book now, so you call it that again. What do they call it? They had a nickname. That's what I'm asking for. Tricyclics were known as the ills, because it was Restoril. And even Flexeril, which is not a TCA, has chemical properties similar. So you always wonder how these drugs get their names and the breakdown of it. But even Flexeril has some tricyclics or mimics in an overdose situation. Called the ills. All right, so I would be very familiar with these, and of course, in the dreaded entitled CO2. Nice little lecture in ACLSEP. It is the gold standard now, and I use that term freely. That lots of people adopt that as the term for your gold standard of that. I'll do this, and I'm sure it's well over time for a break. Here's your little graph for your end-tidal CO2 and what's normal. 35 to 45. So we're going to 25, we'll go to 15, and then we'll go to 5. During cardiac arrest, and you have a decent airway, and it's not a phenomenal day, but you're doing things like what would you above 8, so above 15 feet, number to remember, but have it above that. And so let me ask you this. So this is what a normal person should see, 35 to 45. It's continuous, all right? In a cardiac arrest, if you see this, is our tube okay? Yes, it is. Why is it okay? Because you got waveforms. I don't care who you are. There's not a soul on planet Earth that can argue. If you have continuous waveform, there's CO2. Therefore, the tube's in the right place, but you have a very low reading. So now why do we have a low reading? There's 2 causes. No? No, and that is the worst kind of dead. I read this the other day. It's kind of funny. It said in EMS there are 2 kinds of dead. There's a kind that you can work on, and there's a kind that you go through their pockets and pants.
Too far.
Has nothing to do with tube placement. One of them is baggy,
There you go. Got one.
which is kind of baggy.
Too fast.
Too fast. You have no CO2. You've blown it all off. But the more common cause of a very substandard waveform is poor quality compressions.
Oh.
If you're not circulating blood, you're not perfusing the lungs. If you're not perfusing the lung, you're not going to have good CO2. So resting on the chest, not rotating, very poor compressor. So that's the cause of that. What's the cause of this?
Something to your monitor.
Nope. Nope. You lost your tube. The most common cause of a secured tube displacement is this right here. And when does that happen? Take backboards off your truck. Nobody needs a backboard anymore. Well, let's take this arrest and move them over to the ER. Well, his stomach's getting bigger. I don't know why. We don't have capnography. Y'all tubed him in the wrong spot. No, we didn't. 25 minutes ago, we didn't put it in the wrong spot. We had capnography. Here it is on the strip. Ooh, try to argue that one in court. Not going to win because I got it. So we have continuous waveform capnography. We'll lose it. What prevents this from doing that? That neck collar. What's the secondary reason you lose it? What prevents that from happening? Head blocks. So backboard head block C collar, and you come into local ED, and the ER doc goes, "Holy cow, it's a traumatic arrest. You should have gone to the trauma center." And the whole time, it's all because you're doing what's right. You had a nice hard surface to put somebody on with carry handles and straps. That's called a backboard, by the way. Maybe the people that take them off the book should read a PHTLS book every now and then, because it still says there's a time and a place for one. All right, so we lost our tube. That's the reason that happens. We got decent. All of a sudden, it does that. What do? That's the only time in ACLS that it says you can say in the middle of a cycle, go, stop, time out, check a pulse, because what perfuses the human heart and lung the best? Their own heartbeat, not your fake attempt at compressions, which is better than nothing. But when you see that jump, you instantly know that there's a potential for ROS, so you can go ahead and say, stop CPR. All right, now we're going to do a little East Coast, West Coast training. We got the shark. Heading towards the West Coast. What's wrong with this patient? Possibly. Could be a leaky cuff because there was retention of that CO2 at the end. What disease process is this? Emphysema COPD, because they have high CO2 where? When? Exhalation. They can't get rid of it. They're trapping. Where's the high CO2 beginning or end? At the end. All right. I'm going to erase these grades again. I'm nervous. So now, like Jaws, we're going towards the East Coast. Shark's going that way. What's wrong with this patient? No CO2 at the end, right? So what disease process has trouble getting air in, not getting air out? Asthma, absolutely. Most of the time, you can recognize an attack and wheezing. Treating it, you don't need waveform.
I've never seen that.
Well, I mean, it just doesn't happen. You know, you always have that one partner. What are you doing? Well, I'm going to get waveform and the cannula on and everything. No, let's put them on a nebulizer first and treat this problem they have. You have one in every crowd. All right, so quick analysis of it. Stand up, because as soon as I'm done, you can take your break. You've got, that literally means stand up. So stand up, we said our normal CO2 is what? 35 to 45. You have a high CO2, it is what? What's wrong with the patient? What's wrong with the patient?
They're retaining.
half birth, half non.
They're acidotic, hyper. If it's less than 35, it is alkalotic. What's on pH? Okay, so if you have a low pH, it is acidotic. It's opposite. So if you have a high pH, it is. You remember these core numbers, it'll kind of get you there. All right, so here's the problem with labs, and so this is where we're going to fix this on registry. Okay, I want you everybody to remember and say with me, raise your right hand. Right is respiratory. Everybody remember that? Okay, so if I give you a CO2 of 55, your CO2 goes up. CO2 is respiratory, right? Got that? If I say a CO2 is 20, right? It's respiratory, it goes down, okay? Some of you may have seen this in the form of a book and confusing this called turn signal. Don't ever pay attention to that. So if right is respiratory, what would be metabolic? Left. So if your pH is 7.2, it is metabolic acidosis. If your pH is 7.6, it is metabolic alkalosis. Okay, so I'm going to give you a number and we'll see what we're going to do. So we're going to go with CO2 of 65. You thought you were going to slip me because I can't see. So respiratory what? Respiratory what? Okay, pH of 7.3. Acidosis, okay. What about CO2 of 36? Keep it right in the middle. It's normal. Okay. All right. So I said right's respiratory, left's metabolic. Remember the word same. Same has the letter M in it. Same direction is metabolic. So if I have a CO2 of 55 and a pH of 7.5, same direction, same as metabolic, ignore respiratory. What's our metabolic finding? Metabolic alkalotic, okay. What if we have a CO2 of 28 and a pH of 7.2? Same direction, right? Same is metabolic, so just pay attention to here. Which direction is it going? Metabolic acidosis. So if same is metabolic, what would opposition be? So we now have a CO2 of 50, a pH of 7.3. Respiratory what? Acidosis. We now have a CO2 of 20. And we have a pH of 7.6. What's our problem? Opposite, respiratory alkalosis. Thank you. Take a break. And so some of you are thinking, well, what if they want to know both? Well, you look at the primary, then follow the direction of the secondary. And it tells you what the other problem is.
Anything. Primarily. The area I'm in has some of the best trout waters.
say the like. Got a bunch of herbs.
He bought it, the outboard needed to be rebuilt, we had it rebuilt. He started having, health problems, and no more water. So he said, he wants to sell it for $12.
Stratus. There's this key, they had another guy who did. Drunk driver, he on him in his 65 Chevrolet. Oh, it.
I know what I want during the week.
Really? You can afford it. Keep that as you go, you know?
My goal right now is just get married and get out of debt.
Well, I mean, if you didn't marry, you would get married, then I'm sure. I think I got to do that when I got married. Because his debt is my debt. I didn't have to get that house to take for it.
We're not ready right now. We're renting my dad's house. I'm working this different job right now. Not 60 miles one way.
This is my last one.
Paris is higher. I'm not sure. It's 62 miles from the house. Whew. We're a small. It's hard to.
That's why I got it to do. Yeah. They got rid of like 8 people. They're bad there. Like 20 something, and like who's on Chip's been there 30 years, he's 50 something. He's like, I let go. He's
Well, that kind of does is we run roughly almost $200. The 2 24-hour trucks, 99 trucks, and at 9 o'clock at night, we're going to address them. If we have a mission, we're going to shut down for an hour and a half. But we don't do many. I don't see how his crews do it. Hardly anything that does the same way, does it?
You know, your broken bones and geriatric fractures and stuff do, and if it's you know, something like pneumonia or something like that, nursing home UTI, they'll take it. They don't like a lot of the other stuff, but we'll take them other stuff. Sometimes they'll keep them, sometimes they'll ship them. But all of our stenties, strokes, traumas, babies, baby deliveries go somewhere else. Absolutely.
Y'all don't come up very much.
Not often, but we do some. We go fishing.
oh, good. I'm not the only one. It's like, man.
Recently, we've got a lot of people that have some medical problems that they're specialists. I mean, like if they cancer and cancer treatment is all fishing, we're not going to waste their time to stop it.
Just leave it. It just started doing some transfers. Here on it. We had 3 trucks. We're doing some community grant stuff. I came in, actually came in from home. I came in and drove for her from 10 to 6. truck at 6, went home, fed my dogs, because my fiance was going to Concord to do stuff for the web. Came back, got there about 7:30. I was covering for one of the night guys, so he could take us a period of flight. It got me hours. I didn't care. I was go back to what I did. Ended up on the truck with the supervisor at 7:30. Was sound like the worst call it was. The person I was supposed to be working with kind of run a call like themselves. We had 5 trucks, and so had another call. They said, understand budget. Good contract. What's it going to take somebody on the commissioner's time?
Same thing when you're talking about. They finally give you, we didn't get the 24-hour truck, they went from a 5-day-a-week, 8 to 4 to 7-day-a-week, 7 or 8 days.
What we asked them for was hire 2 more people. Minimum. Hire 2 more people. And take the supervisor off the truck. Like it is in the letters. And at least you have another bag. So I'm like, I don't recognize it.
I'm keeping this. I'm working on it.
He actually last October sent me all the stuff to get me signed up.
Maybe the same.
It may be. I know he's real big into any kind of fire thing going on. He goes like fire walk the 9/11, all that. He does all this stuff. Yes. It's big, yeah.
Doctor and a paramedic. I've heard 4 to 6 that go to every race. Well, Cabarrus County is a CMC. It's Cabarrus County. We either go to CMC Main or CMC. Or argue question. AMR to my knowledge doesn't have anybody in North Carolina. AMR or rural metro even one, which is sister companies. How would a trauma surgeon become affiliated with something so they could work trauma?
So this is something NASCAR is doing.
Just announced it.
race all over. I don't see any more everywhere. And you're going where the county's at, not gonna, I would be surprised. The medical control for that county, or let somebody come in and do their medical control. I don't see that.
Well, that's what I was trying to figure out, because I sent my boss in. And but I have clue things. I work for Bill. They took me on trucks Friday night with a very, very combative patient. Still, they have, I work down there as a basic functions. They first do my ass, I'm doing on post. Somebody back with me. I should have seen some.
What's the difference? Somebody pulling up in the vein or POV? They're sick.
I have numbers in my phone for that reason. North Carolina. I'm working through. I cannot look at a monitor and tell somebody what's working.
So NASCAR is providing their own doctor and a medic at the infield center. They're still going to utilize the local too.
But that trauma surgeon, that doctor, it has to be a board certified trauma surgeon. And they're the ones who are going to be chasing.
Somebody's physician's medical control doing immediate triage termination at this on the track.
Which we've had. We've had, there's a doctor.
But are they actually on the track?
My understanding is they were in the J-shirt.
That's what that sounds like. You're actually just having somebody train you. On the same with the emergency team project, so we feel straight out.
That's what is great. Because the chase truck has always gone to the most damaged vehicles. Because they've had, if we had to do an inversion roll, they had the stuff in the chase truck to do it. It's not here on the record, it's in the chase truck. Take the recall point. 18 on test car, 18 on deal, whatever the first series is called. There's 22 on. I have no home on the truck. shot. It's supposed to turn 40 minutes.
So before we get back started, is there any problem areas you guys want to talk about or entertain about medical emergencies? But not even necessarily what I've been talking about, but personally, brick walls for you. Just remember the brief moral of the story today is that always consider trauma as a possibility to what is going on for medical patient.
Probably an hour.
Dig too far back. And vice versa to a certain extent. We had that yesterday. A guy ran off the road, one car hit a tree, stroke-like symptoms. What was his problem? Low blood sugar is what caused it. Then yeah, he had some traumatic issues as a result of it. Driving through town, witnesses said weaving all over the road. So they instantly thought it was, drunk driver. It wasn't. So. All right. Please hate that. How does it do that? Way. Okay, so back to our problems. We did our little thing on end-tidal CO2. Oh, here it is. The mnemonics to review. Things to remember. DCAP, DTLS, you tips left out. Sample and remember the sample. Oh, we're back. All right, there they are. I'll just go ahead and if everybody's liking to write, I'll let you have it. So what's what? DCAP BTLS is what you're trying to find in your trauma victims. Be pertinent here in a little bit when you do your assessment for your trauma victim. Shrimp can, what's our shock? Right? How can you tell the difference between compensated and decompensated shock? Because they both present exactly the same, but there's one change. What is it? Blood pressure. when you lose that ability to perfuse, it is now decompensated. All the other stuff remains the same. Decompensated is probably pretty bad. It's one step closer to irreversible.
You said simpler, the R is just. a
Risk factors, it's not in a lot of text. You won't see it on registry as what I know, but it's just an interesting point for you. OPQRST. You should know these. If you add an A to the end of perla, what's that for? A for accommodation. Accommodation meaning what? Consensual light reflex. Shine it in the right eye, the left eye constricts. Remember the CAB now instead of ABC. Talked about sludge earlier. Here it is. Now we're moving into the pediatric portions of the medical. Remember the portions of PAT. What are they? 3 components. Circulation to skin is one of them. Breathing is one of them. Appearance, work of breathing, circulation to skin. That's the legs of the pediatric assessment triangle, which is really an assessment that can be used on anybody because it's an across the room assessment. And in PEP, it's designed to say whether you want to stay and play or load and go. And we'll talk about that in just a little bit. Tickles, which is also in PEP, tone interactiveness, consolability, look and speech. Is it appropriate for this age? Is it appropriate for this patient? How many can tell me what APGAR is? Yep, you're right. You're right. Yep. I don't know. Are you asking me or you're telling me? There's no yes. It's one or the other.
Yeah, that's it.
That's it. Whatever it is. Yeah. I like that when I throw out a couple answers. Somebody say which one? And I say I don't know which one was right. That one. That one. Appearance, pulse, grimace, or activity, pulse, grimace, appearance, respirations. When should an APGAR be done? 1 in 5. And that's actually, I want to say it's in your data. If you ever deliver a baby, that is a requirement in your data entry. If that's what you do for the state of North Carolina. It's, they want to know what the APGAR was at 1 and what it was at 5. Should it be better at 5? Absolutely. How long can you have acrocyanosis? Anyone tell me what acrocyanosis is? Babies have acrocyanosis. Yes, bluing to the limbs, specifically hands and feet or limbs. And it's a normal finding for a newborn. At what point should it no longer be a normal finding? Very important question. Anybody in Webland wants to take that one? How far out does acrocyanosis go? Nobody. 2 weeks. At as max as 2 weeks. It's not often 2 weeks, but it can be a max of 2 weeks, and it's a normal finding. It should not be after 2 weeks. After 2 weeks, it's the presence of hypoperfusion. That's the tail end of it. Yes, it can be 2 weeks. That's pushing it. Like I said, it's not common, but it can be, and it's normal. Dope. What is dope? What are we talking about when we talk about dope? Placement of the tube. It's not working, so we're problem solving. What's wrong with the tube? So what's the D stand for? Displacement. O. Obstruction. P. Pneumo. Thank you. I hear Maria. E.
Equipment.
A bag valve mask made in the Philippines by somebody getting 10 cents a day. Equipment failure. Something's wrong with the equipment. Absolutely. Obstructed could be anything from your firefighter with the BBM is trying to talk to his girlfriend and wife on the cell phone, and the bag valve mask is on the side and the tube's got the kink in it. It could be vomitus that has now come up and done its thing. Or like the most horrific code I ever ran, it was a peanut butter and jelly sandwich shoved halfway up the ET tube. You look at the cords and you're like, man, it looks fine. Place the tube, brick wall, doesn't squeeze. Go to the dope. Is it displaced? Nope. Why should you go through the cord? Is it obstructed? I don't know. Run the suction catheter down, it goes halfway and it stops. What do? Pull it. Pull the tube out, halfway down below the cords, peanut butter and jelly and white bread. There was no way to clear that tube. Threw it away and grabbed another one. Pneumothorax. Yeah. Just and that feels like a brick wall. And if you've ever been ventilating when somebody decompresses, it's pretty cool because it won't ventilate, and all of a sudden the bag squeezes as the chest shrinks. Equipment failure. Lemon. This is the great one. If you work for a service that doesn't do RSI, should you still know RSI, or North Carolina Drug Assisted Innovation for National Registry? Absolutely, because it is a national standard. Look, evaluate, 332 law. Melon potty. What's the melon potty? What are you looking at?
Open their mouth so you can see all the structures.
Can you see all the structures? I like to call it the uvula scale. If you can see the, what does it start with, Maria? Is it a 5 or a 4?
Oh, you go from 1 to 4.
1 to 4.
1 is you can see everything.
Yep.
2 a little less, 3 a little less, and then 4 nothing.
That's absolutely correct. So 1 is where you see everything, and like here's the tongue, and you see uvula, and you see airtime here. You see everything around it, and basically from that goes to a tube where you can still see air, but you're not seeing the tip of the uvula, down to a, that's about all you're seeing. That's not what you want to see. That's not somebody I want to try and manipulate and try and get a tube in. So mountain potty is a really good tool to evaluate. Obstruction, neck immobility. The tongue is just a terrible thing to overcome when you're trying to innovate. Everybody has a preference in their laryngoscopes, but you need to be proficient in both of your blades or what you have, because everything has its limitation. I have the pride and joy to say on 2 calls I made Regional 1's glide scope not work. Number 1, I'm heck on electronics, and number 2, they just couldn't get the tube in. But the number 4 Miller did its thing. So for those of you that hate the Millers, there's a time and a place for one. It's that difficult one that nothing else works in. H's and T's. Now this was popular 15, 20 years ago for your pediatrics. Is why is this child arresting? Now it's in common ACLS adults, and it's the big emphasis for PEA and asystole, and it should be considered in all codes after the first round of medications are done and there's no change in the patient's status. H's are hypovolemia, hypoxia, hydrogen, acidosis, hyperkalemia, hypothermia. The T's: tension pneumo, tamponade, toxins, pulmonary thrombus, and coronary thrombus. Now, a lot of these are sort of history based. Can't find them, But I'll tell you the good news about this, and this will help you with registry. In a cardiac arrest, when everything is going correctly, in other words, I don't care if you got them tubed or not, but you have chest rise and fall with a back valve mask, and it's good. Do you need to consider hypoxia as one of your H's? No, because by default, you've eliminated it. When you guys start an IV on a code, do you put a 22 in the back of the hand and let it run KBO? Or if you have an AC or something, or an XJ or something, do you turn it on and let it run, or do you turn it off and turn it on every time you do drug push? What usually happens in a code?
Let it run.
Let it go. So by default, I'm not saying you fixed hypovolemia, but have you worked on it?
Yes.
All right. Raise your hand if you're with the fire service at some point. All right. What's the solution to pollution? Solution to pollution is dilution. So if you have an acidotic patient, before we start pushing bicarb, what are we trying first? That normazolone medication we carry. So we give, we give 250 to 500 of normazolone, saline. And so the solution to pollution is dilution, even though we've not tried to treat our acidotic patient. Have we, by default, by letting our IV go, as we all do during a code, have we by default started working on it? Same with hyperkalemia. With our pneumo, if we're not having any trouble with our BVM at all, and we have equal chest rise and fall, are we worried about that? No, it's not an issue. If it's, well, let's say he does have a pneumo, what kind of issue does he have? What kind of pneumo does he have?
Really want to get him CPR.
He's got a simple. Because if he's got a tension, we're going to know it, because we have poor compliance, we have other signs and symptoms of shock, unequal chest rise, all the textbook stuff associated with it, other than the tracheal deviation, which is, that actually came about from X-ray, not something visual, but it's in the books as a late sign. You consider death a late sign, then I'll go with that. And the worst thing you'll ever see is that JVD, signs of shock. That's when you decompress. That is signs of shock. It's not absent sounds. It's not tracheal deviation. It's absent sounds and presence of shock, meaning that it's a tension. It's a true tension. If not, then it's just a simple pneumo. Who cares? All right. Want to know the valves? That's a good one to remember it. Do you know the other, and I'm here in land, I'm going to pull a Glenn, I'm going to curse. Do you know how to remember this one? Toilet paper my ass, thank you. Hey, that came from a student before me, so I'm good. Layers. Just remember that. Anything else? There's all kinds of them. Anything that you want to know. I love this one. So you're going through all the things, and the street medic says, we left here with the patient an hour ago. Quit worrying about it.
Go back to the mom. Oh, never mind. I missed the X's.
Anybody want to tell me why it's called the arachnoid matter? Looks like a spider web. There's some people in here that have done some good training before. Good deal. All right, so review of the things that you need to know medically wise, the good HA stuff. The out is ABC, in is CAB. The things that have changed, is the compression depth, the AED used for, what does it say about AED used for infants? What's the golden rule for AEDs and infants? If you have a set of pads for infants, use those on the infants. But if you don't, use the adults, because a higher voltage of energy is better than no voltage of energy. What they discovered about 2 updates ago was that pediatrics responded identically to adults in the presence of VFib and pulses VTAC. But for years we were told, oh, it was all respiratory. We're going to worry about airway. We're going to do this. We're going to do about that. If it's VFib, you defib. That's the moral of the story. Solution to VFib is defib. Don't care how old you are. High quality CPR, the rate's over 100 to 120. Cricoid pressure was taken out. And of course, our compression ratios, it's always a good one. I'm going to skip through the case studies. Well, I'll give you one. 6-month-old baby girl found a crib. Mom says she's not breathing, 40 weeks, no medical problems. Went in the same room, another crib. BSI seen safety. Determine responsibility for signs of breathing. This is just a process. Call 911, get an AED. Check for pulse. Start CPR 30 to 2 because you're by yourself. What's it turn into if there's 2 of you?
15 to 2.
Goes, the ratio changes 15 for the 2 rescuers. And what type of CPR?
2
2
rescuers.
thumbs encircling, correct. There you go. All right, I'll keep going until we get out of the AHA stuff. Oh, probably can just do this. Let's do that. All right, so with our ACLS changes. All right, CPR quality, we already talked about that. Team approach, no pulse check after defib. You always find somebody in ACLS that still wants to do that. You move right back into compressions if you defib. Stack shock or 1 shot, we just do the 1 shot. What does AHA say about your defibrillator setting? Manufacturer's recommendation, or both are acceptable answers. Also known as, depending on the machine, the highest setting the machine has. For most biphasics, is 200. But just the blanket statement of manufacturer's recommendations are the highest one in there. Hospital people have a little bit different. You may have a policy that says you have to do this and this and this. It just is very dependent on it. But you know, the less energy through the heart, the better. And even though it's at a higher dosage of energy, you're doing it less often. So that's the reason for it. Atropine only for profound symptomatic bradycardia. Dopamine, pacing, epinephrine drip are all on the same playing field now. It is generally more safer and more beneficial to the patient to try dopamine or an epinephrine infusion for bradycardia. Pacing sends, you're cooking the heart. And yes, it will work, and it's wonderful, and it's very aggressive. However, if the patient's been that way all day long, you're probably going to kill them. That's just a little side note there. Don't try to fix your patients in 30 seconds unless they got sick in 30 seconds. Anaphylaxis, you should fix that in 30 seconds. Relatively perfusing VTAC that's been there for 2 days, you don't need to fix that in 30 seconds. And it's perfusing. So just think about stuff like that. Sodium bicarb only for documented acidosis. They do say a little blurb in there, like for pre-hospital providers, you don't have that. Dialysis person would that didn't have it. But if you have high index of suspicion for it, whatever your protocol says. And adenosine also stable, undifferentiated regular monomorphic wide complex. And also the other thing about adenosine was changed in the last update is if you use it for your SVT and your underlying rhythm or your rebound rhythm is atrial fib, then adenosine was used as a diagnostic test, and you do not need to continue with it. If it goes right back to SVT, you go to what?
Cardioversion.
Can't hear you.
Cardioversion.
Not yet, but it starts with a C. Cardizem, because your underlying rhythm is atrial fib before it goes back to SVT. Doesn't convert after that, then cardioversion is going to be an option to it. But just remember, if you have an underlying rhythm that shows up after adenosine, and it's something that can be treated with something else, that's what your problem is. And yes, you can give adenosine again, it's just only going to do the same thing again. It's not going to fix it. So good consideration of that. All right, so got a patient, sinus bradycardia, rate of 36. Atropine has been administered to a total of 3 milligrams. What's the maximum dosage of atropine?
30 milligrams.
3 milligrams. The pacer has failed to capture, and that is sort of common. Patient's confused. The blood pressure is 110/60 now. Which of the following is now indicated? Can you give more atropine? So that's
No.
dopamine.
You don't need it, that pressure.
Don't need it with that pressure. And what's wrong with the dopamine dosage?
It's too high.
It's the pressure dosage, it's not the rate dosage. Dopamine truly has 3 dosages. Has a renal dosage of up to 5 mics. Even though that's in the drug insert and in ACLS, in the field, you usually are not giving less than 5 mics per kilo per minute of dopamine because it lowers blood pressure by increasing perfusion to the kidneys. So you're looking at 5 to 10. 5 to 10 might be an appropriate answer, but it's not up there. Normal saline bolus. Again, like Maria said, the blood pressure is too good, so we don't need saline. How about epinephrine 2 to 10 for the rate?
Yeah.
This question stinks because the person's perfusing. We don't know what the perfusion status was before the atropine, but apparently it was lousy, or we wouldn't have given up to 3 milligrams of atropine. So that would be the answer I would go with. Again, even though the medication may be correct, the dosage may be incorrect. So pay attention and don't just jump on the first thing. Which of the following statements about magnesium in cardiac arrest is most accurate?
B. Indicated for Torsades, VTAC, pulses, or CSTM pulses, VTAC.
Kind of gave this one to you. Which one?
B.
B as in boy?
B as in boy.
What do you guys think? Right. Now, what's the other name for Torsades? You may not see Torsades in registry. Polymorphic.
VTAC.
And it also has another name. What could it be? Aside from polymorphic, it can be called irregular VTAC or Torsades. So there's 3 sort of interchangeable names. So irregular VTAC, yes. Because VTAC is regular. Irregular VTAC or polymorphic VTAC or Torsades is where there's a fight over the conduction level. And so, yes, magnesium is used for that. What is the other unusual thing about Torsades? It's the only person you're going to defibrillate that has a pulse. Why do you not cardiovert Torsades? What's the other name for Torsades? What's the other name for it? Polymorphic. So if it's irregular VTAC, will a machine synchronize to it? No. So you give an unsynchronized shock, which is also called defibrillation. Thank you. Possible STLS elevated MI, ongoing chest discomfort, which of the following would be a contradiction for administration of nitrates? Talked briefly about this one earlier, but didn't go into detail.
D. Use phosphate. I can't say that word.
Yeah, whatever that word is, yes.
Viagra
and they say
stimulants.
12 hours because Viagra's 12. Viagra's within 24, the Vitra's within 48 because it's a long acting. So, and it doesn't cause an irreversible drop in blood pressure. It causes an unsteady, unpredictable drop in blood pressure because you've got 2 drugs that are synergistic and they lower blood pressure. That's how the phosphodiesterase medication started working, is that they were used to treat high blood pressure because it dilated the vasculature in the pelvic region. And so for males and females, it had a good side effect. The patient with refractory VFib, what's that mean? You shocked him and it's still there. Received multiple appropriate defibrillations, epinephrine, 1 milligram IV twice. This is telling you how far you're into the cycle. Initial dose of 300 of amiodarone. Patient's intubated. Second dose is now called for. What's the second dose? Yeah, and it's also the second dose if the patient has a pulse. Repeat dosage of amiodarone is always 150. All right, I'm trying to keep on moving here. Let's get out of cardiac. I think we've done that. Oh, I think we are. Okay, let's do our peds for medical. Oh, shoot. I did that, didn't I? Yep, everybody saw Mr. Titty. All right, so here's the big thing on oxygen. So what's the oxygen saturation have to be before you give oxygen? Less than 94. And why is that? Want to take a stab?
Free radicals and oxygen toxicity.
Yeah, we'll talk about that. What the moral of the story is in your always looks like this. And what are these little guys that come off of it? And then you have a clot here. And these guys open up and they allow blood flow, not great blood flow, but some blood flow to the heart. What is that called? Collateral circulation. The anatomical term is anastomosis. And how do these things work? They're based upon what? Just like in the brain. Oxygen levels. So here we have our first responder show up with a guy with excruciating chest pain, and his oxygen saturation is 98%. What do they put him on? Because they're having chest pain and they're pale. High flow is 2. What happens to the blood that was opened up and going to where the problem with the heart is that's not getting it? What's that oxygen do, that non-rebreather do? Makes these guys shut off and go back to normal, which is flat, not carrying any blood, thus increasing the size of the infarct. So there you go. Yes, there are some people that don't have much of a collateral circulation. It's just genetics. But if you've always wondered why the oxygen saturation is cautious, that is why. Because if the body has plenty of oxygen, it is fixing itself. If it doesn't, then they need oxygen. That's great. But quite often, even in your trauma patients, up until the moment of death, the body does try and fix itself. It does. All right, so next thing on O2-SAT, the defibrillation really didn't change, but it did say, do not ever exceed 10 joules per kilo. That's the magic number for peds. Or, what's the or? Think about somebody orange or green on Roslow. I'm talking about somebody orange or green on Roslow. So you don't give above 10 joules per kilo or go beyond the adult setting of it, which to me makes no sense because on the adult, I can't go above the adult setting. So, it's just a statement, but it's there. So, recommendation about calcium. We never gave calcium routinely for cardiac arrest anyway. Just make sure if you've got a reason to give calcium, you've got a reason to give calcium. Therapeutic hypothermia may be considered for peds as well as adults. It's now called what? Target temperature management. Exhaled CO2 for all that is good. So this is a good one. A child experiences low cardiac output state. He or she relies most on what? Don't read far into this. In other words, in pediatrics, we don't check blood pressure too much on kids less than 6. What do we check mostly on kids less than 6? To show perfusion. That would be the correct answer. You know all this stuff. It's just not been put in the order that you're used to. Respect CPR and foreign body airway obstruction procedures. The child should be treated as an adult once. What's the golden rule now? Sexual characteristics, which are breast development in females, facial / armpit / chest hair in males. feel anymore sometimes. It's story for another day. 10-month-old infant presents with acute onset of increased work of breathing. According to the infant's mother, the child was crawling around the living room and was fine 10 minutes ago. Feels the infant appears to be alert, has loud inspiratory stridor, and pink skin. So what are we dealing with? A partial airway obstruction. According to PEP, is this a stay and play or load and go? Why? You don't want it to become a complete. So, but according to AHA, as far as our choking algorithm, this is where we're at. So what would the answer be? Oh, it is PEP, I'm sorry. What's wrong with C? That's okay if you get it out, but what's wrong with C? That's okay, but what else do you need? Correct. It's not complete. It's not complete. It's the wrong answer. Pediatric assessment trial was designed to, let's see if y'all remember that from about 15 minutes ago. LPMS provider forms a hands-off general impression of the child. So across the room assessment or hands-off, what's hands-off mean is that you're not physically assessing the patient, causing him or her to swallow their head off. Conscious child in a sniffing position, what's that indicated of? Try this one. Always remember that aligning of the axis. True sniffing position is more of a forward and up, not the head tilt chin lift that we do that kills an airway. So, you know, it just makes the movement of that air a straight shot in the lungs. 7-year-old conscious with marked respiratory distress. Your assessment reveals present intercostal and subclavicular retractions and nasal flaring. So these are bad signs of respiratory distress. Saturation is 93. Why is that an important number? Less than 94, correct. Heart rate is rapid, appropriate initial treatment. What's the key word in that statement? And why is that the key word? Because it's in huge letters, right? I'm not trying to be stupid. I'm being honest with you. It's there for a reason. So what's our answer? There's two things on this planet that are neglected for pediatric care. One of them is the use of a bag valve mask to a living child is very often neglected. I don't know why we think it's made of molten lava or something that's going to kill a kid. A bag valve mask is a very underused piece of equipment for pediatrics. The other one is epinephrine, the naturally occurring substance in the body. The non-cardiac related patient is a pediatric. Again, the 94-year-old guy that weighs 400 pounds with a cigarette and a couple of bars. Epinephrine's rough on him. So in the presence of anaphylaxis or suspected anaphylaxis, we're not dosing peds. And no one knows why, other than it's a ped and I don't want to hurt them. How about we help them for this pinch? So yes, those of you that said A were correct. I'm an opinionated rascal, aren't I? I'm sorry. Identified risk factors associated with sudden infant death syndrome include all the following except. What is it? Everyone should know this. Everyone in here should know this. Because of the saying, put your baby back to bed. Place them on their back, which gives you the supine position. So sleeping in the supine position is not a risk factor, therefore the correct answer. Resuscitation of child with PEA. All right, so what did we say before about PEA and asystole? What are some key factors in resolving it? Say it loud. The people in Webland can't hear you. H's and T's. All right, so what up here has to do with H's and T's? Possible causes. child circulation at skin pallor. So again, here's one of those keywords, most indicative of. B is correct. Is the best answer, most indicative of. Ooh, what did we talk about earlier? Acrocyanosis. What's correct about it? This says 2 months. It's supposed to be 2 weeks. Yeah. And they're typically cold. All right. Gosh, we got 10 minutes. Let's breeze through a little bit about burns, because what I say you need to know and write down on your dry erase board. Parkland formula, rule of nines, be familiar with that. Know the difference between the two. There it would be. The palmar method is the patient's palm. You want to know how you can cheat? It's the patient's palm, right? So if you give me a test question and say it's circumferential of the left arm, I don't know how big the patient is. I don't see his hand. I know how big mine is. I see mine. There's that's the rule of nines and the Palmer method. And there's the Parkland form burn formula. Anybody ever heard of the Brook formula? It is identical to this, but it's 2 milliliters. Just cuts in half. Brook's often used by the military. Why would it be less? Who are they working on? 18 to 22-year-old healthy adults. Typically. Again, weight in kilograms. Make sure you do the longhand method of figuring out what the kilos are for the patient from pounds. They're not going to make it easy for you.
When you say the longhand, what are you saying?
In other words, don't do some method like cut off a number, add whatever to
Divided
it.
by 2.
Yeah, actually divide it by 2.25 and get your answer that way. Don't try and cheat. Don't cut it in half and add 10 or whatever.
2.2 or 2.25?
Or whatever the actual calculation. 2.2. Okay. See, that's why I got that answer with W. I tried to pull a Mr. Spock and get like 18 numbers out of it. All right, so let's do a couple more. So here's a good one. That's about the cardiac burns. 24-year-old struck by lightning with the patient. The area of safety, didn't provide anything else. Patient is pulseless and apneic. CPR monitor feels a systole. What's the most important treatment for this?
The most important thing is restart the heart.
True. Remember what we talked about briefly about our lightning strikes. And we're working them, so it's not about a triage portion. Right, because what factor does that throw in there as an emphasis? On ventilating. Defibrillate if necessary. They will go into VFib at some point in time, and quite often those are one-shot recoveries once they do. Lots of stuff is jacked up when somebody's struck by lightning or severely electrocuted, but if they make it through that first little bit by compressions and focusing on the airway and oxygenation and a defibrillation, probably amio or lidocaine to decrease that irritability, these people usually do pretty good associated with it. Let me get to another one. All right, here we go. You'll see that one like this. So y'all whip your pencils out and do this. Carrying 41-year-old man is trapped in a burning house, being rescued by firefighters. Full thickness burns to his head, anterior trunk, mixed partial full thickness burns to both anterior upper extremities. What percentage of his total body surface area? And how would you calculate that so fast? Or was that a guess? C's correct.
Yeah, it's 9, 9,
That's it. It's just math. That's it. Don't make anything difficult. That's it. All right, we'll do this one. According to Rule of Nines, adult man with partial and full thickness burns to his head, and they do word it that way. They don't just say in burns. They say partial, full thickness. Does it matter? It's still a burn, and you're calculating size of the burn. What percentage? All right, I'll find another good one. That's a good part of the formula written out there for you. That's how you do it. And that would be kind of the answer that we're looking for. 344. That's a good question because it says how much normal saline receive in 30 minutes. All right, so there's a lot of stuff that we went over today. A lot of PowerPoint, some discussion and all that kind of stuff. Trauma, we're talking about head problem stuff, so trauma will be tomorrow. So you guys, any medical emergencies or issues that wasn't on any of the lists that I just showed you, et cetera, et cetera. Okay, well, we'll stop it there and y'all take a break and we'll get the, if you need to see Glenn, if you're going, please do. Encourage you to help with the station, be a victim, I don't know, something. Or we'll continue with the station practice here shortly. Take a quick break first.
Make sure you're taking the right one. That's why they test back. Reading these up here. And realize I took the basic test yesterday.
Hopefully you did good on the facing.
Didn't have any problem, apparently.
You gonna do your test first?
Yeah, that was real nice. I had you looking up there and reading, and I'm like, damn, this looks familiar. And I'm like, reading the top of it, I'm like, oh crap, it's the wrong test.
For the 9 participants still on Zoom, we are starting stations today, so we are done with Zoom. Oh.
Boom, boom.
Zoom, boom.